I'm waiting for the red button. I think we are there, James, aren't we? Right, good morning, everybody, and good morning to all of those of you that I can't see. It's a lovely autumn morning, but I'm afraid you're going to spend the morning in front of your devices. But I hope it'll be a really productive meeting. We've got quite a long agenda and a lot to get through. But it's really good to have you all here. And I am sorry, because I know that many of you were getting slightly excited that we were actually going to meet face to face for the first time as a board for what must be over 18 months. And it didn't quite work this time for a variety of reasons. And given the rate of infection in the community, it's probably a very sensible thing that we didn't. However, I do hope very sincerely that when we meet again, the next meeting will be face to face. We found premises which make it possible for us to meet safely face to face. And I do think, although this is a wonderfully convenient way of working, I do think we've lost something in the humanity of coming together, of being able to have a cup of coffee, and actually those asides that happen before and after a meeting that help to bring the humanity to what we do. So I'm going to move straight into the agenda at that point. George, do we have apologies?
We've just got Paul Molyneux, who'll be in partial attendance. I haven't received any other apologies.
Okay, does anybody else know of any that I need to record? I'll take that as no, thank you. Declarations of interest. Do I have any additional declarations of interest? Take that as no. Questions from the public. I'm going to come to Clive and then to Liz, both of whom have a question. Clive, can I come to you first?
Yes, my question was on 15, the new trust strategy. In view of the very clear trust strategy to be first on its core objectives, is it acceptable that in being first for the future, the trust has an ambition of a CQC rating by 2026 of good? I would have thought surely to be first, the trust rating needs to be outstanding. So I wonder what the view is of that.
Thank you, Clive. And it's a really good question, and one which I can assure you the board debated long and hard, and there was not a difference of opinion in the nicest possible way. Craig, I'm going to come to you because for me this lies at the heart of what we're trying to achieve, and I absolutely get the logic of what Clive is saying, but before I say anything, I'll come to you, Craig.
Thanks, Sheila, and thank you, Clive. As Sheila said, this was debated. I think there are a couple of points that I'd like to make. The first one of those is that the acronym FIRST does reflect our trust values rather than necessarily a position in a competition, although there is obviously allusion to that. But the metrics, and those are at the end of the strategy document that's presented today. The metrics were co-produced, so they reflect the collective views of a number of stakeholders. And as Sheila said, this was debated. There wasn't unanimity in terms of what the target should be. The debate went along the lines of that to be good is felt to be entirely within our control. And so in terms of coming up with metrics and targets that would go into the strategy, those should be achievable, but they should also be within our control. In terms of a measure of outstanding, there will undoubtedly, as there are now, there are areas of the organisation that are outstanding and there are other areas that aren't. Whether inspectors see those outstanding areas when they come to inspect us on the day and don't see the areas that aren't outstanding is not really within our control. So that was the debate that we had, and the collective view of the stakeholders was that actually the target that goes into the strategy should be to achieve good, because that is within our control.
I think the other element, Clive, was that a trust can become obsessed with that target, with that outstanding target. And certainly I think there were people within the trust who felt that being outstanding had mattered too much to the exclusion of other things. That striving for the outstanding tick in the box mattered more than actually the good, solid day-to-day work. And I think that was certainly part of the debate and part of what I felt. It's very easy to chase that accolade. Chris, you wanted to come in. Chris, you're on mute.
Thank you, Sheila. Clive, as you most probably know, I have direct experience of chairing a trust that went from good to outstanding. And I would endorse and absolutely support everything that Sheila and Craig have just said. You cannot chase outstanding. I think it's beholden to all of us to provide the best service, the safest, the highest quality outcomes that we can for the people we look after. Outstanding really is a reflection of what CQC finds. In a sense, it's a sort of acknowledgement of some best practice. But I think if you start chasing outstanding, you're chasing something which actually runs the risk of subverting all the good, solid work that you're doing right across the patch. We strive always to be the best we possibly can. If CQC come along and find that it's phenomenal and give us an outstanding, all well and good. But we should never try to be anything other than the best we possibly can.
The icing on the cake rather than the cake itself.
Yeah.
Clive, did you want to come back, or are you happy with what? Do you understand why we finished up where we did?
I do understand, yes. I thought it's this issue of first, you know, the ambition to be first. It is the way you interpret that, isn't it? Is one of the things that.
Yeah, but it's not a competition.
Thank you, Clive. That was a really thoughtful question. Liz, can I come to you, please?
Yes, and when I say this, it's a question, it's an observation, and I don't want to be a comment that downplays anything to do with, which you'll understand when I come upon it. I attended the 5 o'clock club last night, and I have to say, an outstanding speaker. And I was very impressed with what Michael had to say, and it made me think about our reactions to challenge. The maternity whistleblowing being one, and it's created a subject that we're all talking and thinking about. The scrutiny on maternity itself has created a lot of report writing, which I'm sure creates stress and anxiety to those producing it. If it is a given that we have to do this, could we now be bold and concentrate on the needs of our teams and the needs of our leaders, and in doing so resolve issues that face us? And sorry if it's not in any way a criticism to maternity. I just feel that the reports are huge, and I just wonder, Sue and I mentioned yesterday, are we creating an industry with something else that we were talking about? And I don't want it to take away what we really should be doing, which is caring for our people.
Liz, that's a really powerful contribution, and I think you've given actually us pause for thought about where we start from when there are issues. So I could see you nodding vigorously. Do you just want to come in at that point? Because I think we all have deep concerns about maternity and caring for the staff there.
Thank you, Liz, and you're quite right. There is an industry, certainly within maternity, at least maternity, where they do have to produce an awful lot of reports and a lot of responses to national and regional requests. So I think we need to acknowledge that we do need to respond to those. That's absolutely right. With regards to the work we're doing around the whistleblowing, I think, and I'll cover this more in when I come to maternity in my papers, but we have discussed this, and actually you'll know that I'm very much against making action plans for the sake of making action plans. It's more about how do we encourage and transform and improve our services without necessarily having to write reams and reams of paper and reports for that and add additional burdens on the teams. Certainly, this is something we'll be taking through the involvement committee, apologies, and work on a wider trust perspective on what we've learned. So I agree, there are some things that we have to write and we don't have a choice. The things that we don't have to write, it's perhaps how do we look at it in a different way, and how do we provide assurance that A, to our staff that we've listened and heard them, and B, to ourselves as a board that we're actually taking action on it. And I think it's a really good question, actually. We should take it away and have a think about it. And apologies for the background noise.
I didn't realise it was you, Sue. Maybe it's not me. Okay, thank you, Sue, and thank you for a really thought-provoking contribution, Liz.
And I would suggest anybody who wasn't able to attend looks at the recording, because it was excellent.
Yeah, I'm looking forward to seeing all of it. So thank you all very much indeed for your questions. Really great questions this morning. I like a meeting that starts with having our thoughts stirred and provoked in a positive way. That's always a good start to it. Let's make sure we go on like that. So I'm not planning on moving any other timings on the agenda unless somebody has knowledge that somebody needs to get back to a clinical piece of work or something, and I'm seeing no hands up. So that's fine. Minutes of the previous meeting. Can we turn to the minutes of the previous meeting, please? I'm going to take them page by page. I'm sure you've marked them up if you need to raise anything from them. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and 13. Congratulations, George. I think that's 3 months on the trot. So could we then move to the matters arising sheet, please? And if you look at the first sheet of the matters arising, 1974, there's a verbal update coming today. So we're happy to, if anybody's got any questions, can you save it until the appropriate time? The 1985 is due to report in December. So I would suggest, unless anybody has anything outstanding on that. And 1986, we are referring to that later in the day, but it's the work programme which was produced for the Council of Governors, which is a super piece of work, and I think was welcomed by the governors. I'm looking at Liz and hoping to see a nod, not a shake. Thank you. And I think it was well received, and I think it gives a real structure to the work of the governors and connects well with the strategic work we're doing as a board. Okay, in which case can we move? The second page is all complete. So I only intend to take any comments if anybody has any to raise. And I'm not seeing any hands, thank you. So could we move then to the patient story? And so, would you like to present?
Story is from one of our community teams, and Jane is here to present it on behalf of the team. So, Jane, the floor is yours. You're on mute. You're on mute, Jane.
Thank you, Sue. Yes, I'm well aware that we have fairly limited time, so we're going to try and keep this as succinct as possible. But I think it does show a little bit about the work that we're doing in the community, and certainly one aspect of it. Particularly, we started in November 19, we started the virtual ward test and learn in the Newmarket community team, which was very much about how could we get patients out of hospital quicker and give them a full support at home, or how could we support patients at home so they didn't have to go into hospital. And in fact, we found over the months that it ran that in fact keeping people at home became more part of the model than getting people out. I'd like to introduce my community matron and the INT coordinator, the Integrated Neighbourhood Team coordinator, who are very integral parts of the way that the virtual ward worked. And this model has now been embedded into our teams, and we now call it the Enhanced Support at Home Service, because we felt that was a more appropriate name for it as business as usual. Kate and Dee, are you here? Can you put your camera on?
I think it's on.
Camera is on.
Now we can see.
Yeah, camera is
Now
on.
we can. Okay, so Kate Foxwell is our community matron, and Dee Secker is our INC coordinator, who was the first. All the community teams now have an INC coordinator, but Dee was the first, and she really was the cutting edge for how her role would work to coordinate all the services for the patients to give a seamless service in the community. So we're going to talk about a particular patient. We're referring to him as Mr. Q. We have got his permission and his wife's, but we're anonymising him as Mr. Q, who was originally referred to community physio because he hadn't been able to get out of bed since he'd come out of Adam Brooks, having had a fall. And he was found to have low blood pressure and was unable to sit up without feeling dizzy. So the physio had been unable to progress and had asked for a comprehensive geriatric assessment from the community matron. And I'll now hand over to Kate to pick up the story from here. Thank you, Kate.
Hi, as I say, I'm Kate, the community matron for Newmarket. So obviously we ascertained all of his past medical history and everything, but at the initial assessment, we found that actually Mr. Q's main goal was to regain some of his independence, as he really wanted to sit in his chair and be able to do his own writing and admin. The hospital commenced all the medications to try and manage his blood pressure, which was dropping really low when he sat on the side of the bed or stood up. And he was still feeling dizzy on standing and sitting up, and so he had to lay down most of the time and couldn't manage his physiotherapy. His wife was his main person caring for him and was finding this really tricky. And his only real help was a private once-a-day care package. He was in a hospital bed in the living room and on an air mattress, both of which required a power source, but there was actually only one plug socket available. They also had a television that needed to use this power source as well, so it was really difficult. Due to the equipment that was needed and the existing furniture that was already there, there was little room to manoeuvre around the bed, and there were also multiple tripping hazards noted. So because of all of these problems, the decision was made to admit Mr. Q onto the enhanced service, as a multidisciplinary team approach was really needed for his care. Mr. Q was introduced to the service, and it was explained to him why he needed to be admitted onto the enhanced. And it was explained that the professionals involved in his care would be having a Teams meeting at least twice weekly to ensure that the best communication between professionals and make sure that his care was comprehensive and as seamless as possible. He agreed to this, as did his wife. Dee will explain what happened next.
Hello. As INC coordinator, I spoke to Mr. Q's wife and the care provider and arranged for the care package to be increased to twice daily. Initially, we also set up our telehealth monitoring system in light of Mr. Q's heart failure. This monitored continually and informed the community matron and GP of any health issues. At the twice weekly meetings, all professionals involved in Mr. Q's care discussed any issues and solutions agreed, therefore ensuring joined up care. Community matron contacted the interface geriatrician and asked her to review the data and current situation. She suggested adding extra medication for his low blood pressure. This enabled Mr. Q to feel supported and safe taking the medication and helped ease any concerns his wife had. The specialist frailty physio was also asked to review Mr. Q around the low blood pressure issues and mobility and to see if there was anything else that we could offer. It was noted on daily visits that the mattress was regularly turned off due to lack of plug sockets, and Mr. Q sustained a pressure sore on his foot and heel. We again explained how the mattress worked and how vital it was that this was left on. Community matron consulted safeguarding lead for advice, and the suggestion was that we should try and get him admitted to Rosemary Ward in Newmarket. Frailty physio community matron reviewed the patient, and as the medication for his low blood pressure was working, it was agreed a spell on Rosemary Ward would benefit the patient, so it was suggested to Mr. Q and his wife that how beneficial this would be for the patient to have the intensive therapy. Patient and his wife agreed this would be a good idea. Community matron liaised with the patient's GP, who agreed after consulting with the GP and other GPs and the patient. As INC coordinator, I arranged for the patient to have 2 COVID swabs as per protocol, and went to meet the transport at the patient's help to help Mr. Q get out of the property safely and into the ambulance. I also liaised with the GP to ensure all the medication was written up on e-care for the ward and the patient was correctly handed over. In all of this, I kept in constant communication with both patient and his wife. And I visited Mr. Q daily to ensure excellent communication to help with the planned discharge to make it smooth as possible. We also liaised with the tissue viability nurse to ensure assessment of the wounds on the ward. I'll hand back to Kate.
So it was actually a really good outcome for Mr. Q. His medications, as I say, were optimised and his blood pressure stabilised. The frailty physio worked with the physios on the ward to provide intensive therapy, and Mr. Q was able to walk with the frame independently. Dee worked with his wife to remove some of the furniture and tripping hazards in the home so that Mr. Q had somewhere suitable to sit. The therapist completed a home visit to ensure the appropriate equipment was provided. The mattress was replaced with a high-grade static mattress to ensure that it did not need to be plugged in. This was now possible as Mr. Q was able to spend much longer out of bed. Mr. Q came home, and ever since he's been able to get up out of bed with the help of one, and is able to sit in the chair for most of the day. He's eating much more because he's sat up and moving around. His bowels have improved and his pressure sore is healed. Mr. Q has met his goal of sitting up and being able to do his own writing and admin, and so we've negotiated his next goal is to be able to walk out into the garden. Dee referred Mr. Q to the social prescriber for consideration of further volunteer involvement and also to make sure that their benefits are right. I completed a shared care and support plan, and it was agreed with Mr. Q to make sure that there was the best communication between the emergency services if they were called out. This was placed in the yellow folder in the house along with his do not resuscitate order, which he filled in with the GP. Because of a good relationship was built up between Mr. and Mrs. Q and the community matron, a discussion was possible around future care planning, and it was ascertained that he wished to remain at home where possible with his wife. So we've discussed the care options and he knows where to come. Over to Jane.
So it was a really fantastic outcome for this gentleman. He was discharged from the enhanced service but remains under the care of the Newmarket integrated neighbourhood team. Obviously this only is a fraction of all the work that the community teams does, but I think it has shown how we really are trying to work together to be coordinated. And I think this coordination and this working together and the patient only having to tell their story once really helped to build up trust. And I think it was the building up of trust between the professionals and the patient and his family that allowed these excellent outcomes. And we were thrilled as a team to receive a letter from Mrs. Q a little while after he'd been discharged from the enhanced service. And I'm just going to read that out to you now. There is only one word for the treatment my husband has received from the local NHS during the past 18 months, and it's outstanding, from GPs, physiotherapists, district nurses and Newmarket Hospital, etc. For example, last year, excellent expert treatment was given for my husband's edema and leg ulcers by the surgery and the ulcer department at the hospital. After returning from a month in Addenbrooke's Hospital in late January, when he was hardly mobile and bedridden, he was given superb exercises to do by the physiotherapy department, and the district nurses have dealt with his sore feet. In the early summer, a fortnight at Newmarket Hospital worked miracles. There he was able to receive continuous help with his mobility. He returned home able to sit in a chair during the day, no longer bedridden, walk with a frame to the bathroom and lavatory, and he became far more animated too. One could go on and on about his remarkable improvements, so there is only one word: congratulations to everyone.
Thank you, Jane, and thank you, Dee, and thank you, Kate. That is an amazing story. I'm sure one or two other people will want to comment, but for me, that encapsulates what community integrated care is all about. And I know people don't love it like they love bricks and mortar, but they should. They absolutely should. Because, you know, the thing that strikes me about the story, the impact on the family is as huge as the impact on the patient themselves. And I think that's fabulous. Craig.
Thanks, Sheila, and thanks, Kate, Dee, and Jane. It's brilliant to hear that, and as Sheila said, the difference to the family is huge, and that's why we do what we do. To make a difference like that is just fantastic. I suppose as listening to it, one of the things I sensed a bit of frustration about the issue with the power. So a number of times that came up about the fact that the mattress couldn't be plugged in. I'm just wondering whether is it possible to get an electrician to come in? So I was thinking you could just, for the want of a double socket, we could have solved something, but I don't know whether that might not have been possible. But did you try? And are there things that we could get even better at in terms of liaising with other services?
Kate?
Yeah, so we have got some really good links into social services who have some, links with work people, electricians and things like that. In this case, it would have been incredibly difficult just because of the whole dynamics of the situation. And I guess you have to meet everybody in an individual way. So for some people, it would be really good to try and sort out their electrics and things. In this case, that wouldn't have been the case. It wouldn't have worked. But certainly we have got some really good links into volunteer services that will provide certain services, and also social services can help us as well. So, yeah.
I mean, that was what was going through my mind. I can remember in West Norfolk, there was a kind of home help team that changed light bulbs and fixed stair rails, and there were electricians and carpenters and all sorts who were part of it. And that's great. If you can tap into that kind of voluntary care, it's hugely beneficial. Alan and then Clem.
Dee and Kay for a great story. I'm conscious we only have one community hospital in our alliance area, and it was a great use of Newmarket. Have the teams talked about how we could roll out something like this in the more remote areas like Sudbury and Haverhill and other areas where we don't have the benefit of a mini hospital nearby? Is that something the teams are thinking about?
Well, there are community beds, even though we don't have a community hospital. So obviously in Sudbury, there's Hazel Court, and there are community beds in Bury. Where else are there community beds, Kate?
So we've got Glastonbury Court.
Glastonbury, yes.
Very town, very rural. But I mean, people can come up to Newmarket Hospital as well. There is no reason why they can't use those CAB beds. And certainly there's an enhanced service in most of the areas of the Alliance now. We're still, it's not completely rolled out, but it's almost completely rolled out. We are very lucky in Newmarket because we have Newmarket Hospital, but but that doesn't mean that the possibilities to do this more seamlessly are not across the whole of the Alliance, because they are. People have to travel a little bit further, but as I say, CAB beds for Hazel Court and Glastonbury Court are worked in the same way as Newmarket Hospital. They still get the same therapy and things.
Thank you for the question, Alan. Clem.
Thank you very much, Sheila. Just wanted to outline this case does reflect the good work that is happening in the community, the strength of the partnership, working with the voluntary and community sectors outlined through introducing social prescribing, working with the care provider to increase the package of care initially, I think has been really helpful. What we've seen from this case is the intervention from colleagues, in particular the physio, has actually did actually prevent a crisis from developing. The reablement support has actually enabled this gentleman's independence to be maintained for longer. And the advanced planning arrangements that were put in place, again, are really positive, because we now know in future how to support this family. So credit to Kate, Denise and Jane for your leadership on continuing to support the team. Thank you.
Thank you very much. And I do wonder if we should broadcast stories like this, case studies like this, more widely, because I think it's building people's confidence in feeling that hospital is not the only place where their loved ones can be improved and made better, or it's that automatic thing with families that they want them in a hospital bed, and it's not always the best thing, as we've just heard illustrated. It was part of it, but not the whole. Chris, and then I'm going to move on to Craig's report.
Yeah, a great outcome and wonderful work by the community teams. I just wanted to sort of make the point that community support, enhanced support, is not on a parallel line with the acute support. If we're going to free up capacity in the hospital, we have to enhance the capability and strengthen the depth of working, keeping people well in their lives, in their communities. The two are dramatically interlinked. And so I think when we talk about integrated working, it's that interface with what's going on in the hospital is so fundamentally important. But I'm really encouraged to hear this. I mean, let's hear more of these stories, because every story is a great success. Because I think in the old days, this person would have come on into the hospital and the outcomes would not have been as good, I'm sure. Well done.
Thank you.
Thank you, Chris. I think you've said everything, so I won't repeat what you've said, but I'm really grateful, Jane and Denise and Kate, for you bringing that story to us. As I say, I think it's a case study. Those kind of case studies do need more wider sharing. So Helen Davis, that is, I will chat to you about that, because I do think that we need to change the public's perception, and we need them to love their community teams just as much as they've ever loved the small bricks and mortar, and the big bricks and mortar come to that. Okay, thank you, all three of you, very, very much for a great, powerful story.
We're going to dip out of the meeting now, if that's all right.
That's absolutely fine, though. You're very welcome to wish, but you've probably got patients to deal with.
Yeah. Okay, thank you. Bye.
Thank you, Denise.
Thank you. Bye-bye.
Bye. Craig, I'm going to move to your report. You've had a wonderfully positive morning to start with.
Thanks, Sheila. Yes, that suggests that I'm going to change the tone.
No, I was allowing you to ride on the wave of it.
Thank you. There are there's a lot of my report that is a summary of an awful lot of detail that you will hear later in the meeting, and I don't want to basically cross over with all of that. The first point in my report is probably the most important, and I think that's what you will hear today, is an organisation that has been under significant pressure. But also, it's not just the organisation, and you will hear, particularly in Clem's report later on, about the pressure that's being felt by other parts of the system. So we have had our busiest ever days through the emergency department in terms of an assessment of how busy the organisation is. That's one of the measures. Some of our busiest ever days during the summer, and as we look forward to winter, that creates a level of nervousness in the organisation that you will see reflected in some of the later papers. As I said, that pressure is being felt in other parts of the system. Social care are busier than they have ever been, and yet the gap between capacity and demand is greater than it has ever been. Primary care is busier than it has ever been, and some of the comments that have come out over the last couple of days are not the way in which you motivate a workforce. You don't tell people who are working harder than they ever have done that they are underperforming. If there was anything that we learned last night from the talk about compassionate leadership, that's how you motivate people. You motivate people through sharing goals and being empathetic, not telling people they're underperforming. So we do have challenges, and you will see during the course of this morning what we're putting in place in order to address those. You'll also hear about maternity, and the whistleblowing issue is highlighted in my report. It is a department that is under pressure at the moment, and just responding to some of those issues is creating its own pressure. What I would say, and again this will be touched on later, is it is a really brave thing to do, to speak out, and however people do that, it is much better that people speak out. We might have chosen a different way in which people can speak out, but what we never would want is for people not to feel as if they can speak out. So however they do it, we thank them for doing that, because the reason people are speaking out is because they share our values. They share a desire to provide the best quality of service we possibly can. And when the challenges that we face in doing that become, in our own opinion, unacceptable, then we all have the right to speak out. So those staff have done. Thank you for doing that, because that is by speaking out, that gives us the chance to address that. What I would say is that the issues that were highlighted, principally in terms of staff shortages, is something that we around this table have been speaking about for a while. They're all concerns that we share. We need to get much better at predicting what future demand is going to be, and as an NHS, producing workforce plans that reflect that future demand. It's something that we're not very good at the moment, and we need to get better. I do highlight in my report the issues around the external review. It does look as if we are nearing the point at which that will be published. the rapid review that commenced over 18 months ago has now entered a part of the process called maximalisation. So all those individuals that will be criticised in the report have the opportunity to challenge some of those criticisms on the basis of factual accuracy. That's a 4-week process that started at the beginning of this month, so will end at the end of October, and therefore I think we're in probably December. It will take a while to respond to the responses that they receive through maximalisation. And the final point I would make is around the vaccination programme. So the vaccination programme at the moment is in full swing. Earlier this week, we passed the 1,000 staff mark just over a week, and those vaccinations continue. So we're now going to run that vaccination programme until the first week in November, by which time we aim to get all staff vaccinated. It's worth saying that we've got a number of ways of getting vaccinated. So through work is one area. A number of us will have received the text messages offering us boosters in primary care, and in fact primary care are doing the vast majority of the vaccination programme. So again, another example of how busy they are. Other than that, I'm happy to try and answer any questions.
Thank you, Craig. And oh, I've got an echo. I'm sorry about that. So I'll come straight to Alan.
Hi, Craig. Thanks for your summary. I'm feeling mixed messages at the moment from our board papers and from my interactions with people. On the one side, we hear about, low morale and problems and stress, and then in other areas we're hearing, great stories, even a glimmer of excitement about the medium term. And I wonder, in your position as our new leader, what is it you're really picking up when you go around the organisation, and how are you reflecting that back to people?
So I think that's fair, Alan. And so absolutely, I get that mixture. People are still hugely passionate about the work that we do. And again, the talk last night from Michael West highlighted the shared values that we all have. So coming to work is still a joy for many, the opportunity to provide care. It is a genuine vocation, but notwithstanding that, things are tough in the organisation. The level of demand means that we're not providing the level of service that we would like to, whether that's through the emergency department, whether it is the waiting lists that are building up, whether it's the demands in the community, or indeed in primary care. So that division in terms of still being excited about doing the job, but recognising how tough it is. There are 5,000 staff. You wouldn't expect me to say there is one view, but genuinely, I think exactly what you've highlighted is by and large a reflection of how staff are feeling. They're feeling conflicted.
So the second half of my comment was really, how are you playing it back to them? Are you trying to be just realistic, or the big motivator, or how are you? Yeah. How are you playing your role?
So, and we've talked about this as executive directors, that balance between providing hope and optimism, and balancing that against looking detached from the realities on the ground. So I'm trying to reflect that dilemma. Exactly the way I'm talking now is the way I was talking at staff briefing, the way I'm talking to staff in the organisation, it's I don't have all the answers. I know what we are doing, and we are working across different agencies. We are doing things that will hopefully make it better, but it's not going to feel great as we roll into winter. So I'm trying to reflect exactly that. I'm not picking blind optimism and hope and ignoring the reality, but I'm also not ignoring the things that we are doing that will make it better. And longer term, there is real excitement about the future. So we will be discussing the future system programme at some point, and there are a huge number of people in the organisation that are engaged in looking long term into the future, when there is genuine excitement and genuine hope.
Thank you, Alan. That's a good question, and I think there is that balance between excitement, hope, exhaustion. You know, it is really a fine tightrope, I think, for all of us as leaders, and you know, any of the board members who are out, to kind of strike that balance, but above all to listen and respect where people are, because you know, we are a very big community. And there are lots of communities within that community. I often describe the hospital like a very big village, and villages have communities within communities. And I think that's understanding that different parts of it will be in different places. Do I have any other questions for Craig? In which case, we'll move into the nitty-gritty of the main agenda and delivery for today. And Richard. Insight Committee, please.
Thank you, Sheila. So the report gives the reports from the last two Insight Committee meetings, the last one on the 4th of October. In general terms, I feel that the committee is developing very well. All of the subcommittees that feed into Insight have now met and have developed a consistent reporting process into the Insight Committee. And there's the sense that the delegation of much of the responsibility for monitoring and analysing data to the subcommittees allows us in the Insight Committee to have a proper sort of governance oversight role, which is what we should be doing. And I get a sense of energy within the subcommittees, that they are really grasping the opportunities given to them in a way that's quite exciting, I think. The paper lays out the key issues that we've discussed in the past two meetings. I'll just pick up one or two things. First of all, assurance about the mapping of the outstanding CQC must and should items onto the 3I structure. There's always been a slight concern that with the change to the new governance structure, we might lose sight of those last few items which are still outstanding, but we're very clear now where they map. We've agreed that the CQC Insight publication, which is a publicly available publication, should feed into the Insight Committee. And this is a publication that looks at all of the data available to the CQC and then benchmarks us against all other trusts nationally, and allows us to see those areas that the CQC are picking up where we are performing less well than other trusts, and just make sure that we have a clear view and sight on that, and that we are clear where those areas map onto our own governance structure, so that no surprises when CQC comes around again. And the third issue, which has been a major talking point, no surprises there, is waiting times in various areas, particularly 2-week wait in dermatology and colorectal, and also diagnostic waiting times, particularly in non-obstetric ultrasound and the oscopies. There are clear plans to try and resolve the problems. It's being monitored and will continue to feed into the Insight Committee. I don't think the solutions are easy or necessarily quick, but we are assured that there are plans in foot and a trajectory for recovery in all of those areas. We don't think at the moment, the last two meetings, there have been any issues that need more discussion, particularly at board, but happy to try and answer any questions.
Thank you. Can I open that up for questions? But can I ask one first? I suppose from a board point of view and the board getting assurance, it'd be useful if you just made a general comment on how you see the maturity of both your committee and the committees that feed to it, and kind of what are the priorities for the next period moving forward to develop further that maturity?
Sorry, you broke up there, Sheila, for me. I don't know if it was for everyone else as well or whether I was the only one, but I didn't hear any of that, and many apologies.
It's all right. Let me just gather my thoughts. I was talking about the maturity of the committee from a board assurance point of view, the maturity of the committee and the subcommittees, and kind of what are your priorities for making sure that that maturity continues to grow? What, kind of what next? What do you need to be assured about the subcommittees that feed Insight? Because we as a board need to be assured that the whole flow of information coming up to board is of the level we want it to be. Sorry, that's a bit of an awkward question.
No, it's a good question, and I think it's the key question. Are we getting all the information that we need? Are the subcommittees doing their job properly? Are they analysing the appropriate data? Are we seeing it? Is there stuff we're missing? And that's always the difficulty, isn't it, in the governance process? And some of that comes about obviously from triangulation, things like using the CQC publication, Insight publication, to make sure there aren't areas that we're missing. We know that all of the previous areas that were reporting up through CSEC and all the subgroups that reported through the old governance structure are reporting into our governance structure in one way or another. So we are assured that the old processes are continuing. I think I think you're right. I think my focus as chair of the Insight Committee is to ensure that the subcommittees are doing their job properly and effectively, and that we are getting very clear information about what they are looking at as the key areas where there are concerns and the key areas where we're doing things extraordinarily well, and having assurance about what the plans are to deal with those areas that are not performing so well, and who's monitoring it, and when we're going to find out what the trajectory is. So I think it's what I said earlier. I think that the new makes more sense to me in some ways than the old structure ever used to make, and means that we in the Insight Committee can really focus on governance, on checking that things are being done properly, and not worrying too much about the details, but getting the assurance that the processes are working. It's a process in development. I'm sure the other 3i committee chairs will have their own comments about it's nice to see some consistency so that we all know what we're doing and doing the same sorts of things, and no doubt it will evolve further. But to date, I feel that it's working well. I don't know if other members of my committee wish to comment on that. I know Helen's hand was up.
In which case, I will take Helen next, because that seems a very appropriate flow.
Thank you, Richard. Thank you, Sheila. So I just wanted to alert the committee. It's long been something we've talked about as a board in terms of how we reflect the community division. And there are aspects of our data and information where it is an inclusive piece, and community activity is included, and there are other aspects where it's very different. But Clem and I met with a number of people, including the information team. Can't remember whether it was earlier this week or the end of last week, but whatever, we met fairly recently, and are establishing a community governance group to be an additional subgroup feeding into Insight, which will very specifically pull together a range of community. Thank you, Clem. I've just noticed a comment in the chat to say that it was Tuesday. And that group will also feed in and very specifically represent community, which I think for me, completes the kind of the subgroups feeding in. That's been something that didn't feel quite right. And then the next meeting we'll have a report from that group. And the other thing, I think this is just maybe an appropriate point for me to update the board. Again, I've been having some conversations with Jodie Price, who is backfilling Jo Rayner's role. She has already taken great strides in terms of that data and information piece, and is working with Nikki Yates around those dashboards and information, so that we've got a kind of a nested set of dashboards, if you like, that can be looked at trust level, divisional level, specialty level. We can cut the data in different ways. And I'm pleased to say that there is another meeting planned, because what has been a niggle, I think board members will remember, we reduced the full IQPR in order to reflect where we were during COVID. We do need to bring it back, but there is actually quite a large piece of work to make sure it's reflecting the current metrics, which may be slightly different to what we looked at before. And I know Jodie and Jo were quite worried about just reinstating the old document and effectively appearing to go backwards. What I've agreed with them, because what I'm worried about is that there may be some of the statutory metrics that we're not fully reporting through. So we are looking at the old IQPR, pre-COVID IQPR. We will absolutely make sure all of the statutory metrics that need to be reported are reported from next month. You may see some of those are not in SPC chart format yet, but they will get there. But I didn't want to delay bringing those back round the table while we do the bigger piece of work. And that all feeds into the work of the Insight Committee and overseeing it. So I don't think the data's fully formed, and I think that's a priority for the Insight Committee moving forward.
Thanks, Helen. That's really helpful. And yeah, I would agree with you about bringing them forward, even if we're not quite where we want to be yet. Jude, I think you were next.
Sheila, thanks very much. I was planning to share some reflections on the improvement committee, which I chaired for the first time, and for which you'll see a report later. I was going to share some reflections at that time, but I think in the context of this discussion, it would hopefully be useful to jump in now, because first of all, I'm encouraged by what Richard is saying about the work of the Insight Committee and the work it's doing with the executive governance committees, because essentially from the perspective of the Improvement Committee, the Insight Committee is absolutely fundamental in terms of identifying those issues which we need then to pay attention to as regards activity to address issues or to improve operations, improve performance. So the comment I would make at this stage is that so far all we've been looking at in the Improvement Committee are those items that we already know about. So they are coming from sources such as our PCERT priorities, which have been around for a little while. They're coming from, we mentioned it earlier, the CQC must do and should do. And again, we understand what they are and what activities are taking place and what plans are in place. But for me, the fundamental success of this system, and I recognize I'm coming to this late after the architecture and the discussion has already been put in place, is how we get this flow from the governance committees, what they're doing in terms of their scrutiny of the underlying groups that report to them, how that flows from those committees to Insight and then to us. Because I will see this process as a success once we start to get new items coming through that flow, which is then in essence identifying the things that we then need to move on to, we weren't aware of before, we are aware of now, and we are taking that forward without having an external party coming to us and tapping us on the shoulder and telling us we need to improve. So that's the bit we're missing. And I recognise why, because some of the governance committees are still in the sort of nascent form. So, for example, when the improvement committee met in September, I don't think the clinical effectiveness group had yet met. So it's unrealistic to think we're going to get a flow from there. But as the activity picks up, as things accelerate, if you like, then that's the flow I'm really looking to get from those sources.
Thank you, Jude. And I think that was a really helpful contribution at that point, because, you know, it's about how the whole system works. Well, we will review the feedback, the minutes from specific meetings. It's how the jigsaw fits together and works in an appropriate way to give us as board members assurance. Chris, you've got a particular role as audit chair in terms of oversight.
Yes, thank you very much indeed, Sheila. And I just sort of wanted to add a little bit more to Jude's comments, which I think are very apposite. And it just stresses that this is work in progress. You know, we're on a journey. At the moment, if I look at the key issues, which are the body of the report for September and October, they reflect a very, very broad range of activities. It's reportage at the moment, it's commentary. And I think if we look at the form, where I'm sure it's going to develop, you know, putting something in the BAF risk register column will immediately give us the assurance that the issues that we've already identified on our BAF as the key risks are being covered. Papers attached if appropriate, but, you know, things like the referrals onto improvement committee and involvement committee, action steps, things to bring back, matters arising. I think we're at the beginning of a stage of development, but I think we need a richer document, which will help, therefore, raise issues that we as a board collectively need to address. So I think a great start, Richard, but I think, as I said, we're still on the journey.
And I'm seeing nods from everybody, and I think that's very true. You don't change a system and get it perfect overnight. I think, you know, this will take time, but we can't let it take too much time. There has to be an element of pace here, because it's essential to the capability of the board that we're getting it right. And that's looking from the board perspective, but also it's important to the committees and the people who are on the ground feeding up to us. I have no more hands up at the moment. Helen, yes, sorry.
Sorry, I was just going to pick up on Chris's point, because in terms of the BAF risk, I absolutely agree with you, Chris, adding things on or even removing things, which would be nice. And we have actually done a little bit of that recently. But one of the plans for these committees, previous review of the BAF risks tended to happen outside of these formal groups, and one of the things I know Anne has put forward and we are looking to do is to actually oversee the BAF review in the appropriate committee, whichever one it may be, and pulling those links together. I think it will also be another step of maturity in this process. So yeah.
Thank you for that, Helen. Okay, that's been a really interesting discussion. Alan, I don't know from the involvement committee, I know you'll present your own report, but as we're having the general discussion, I'm happy if you want to make any general points which feed into what Richard and Jude have contributed and Helen's contributed.
I understand all the points there. I think the flow isn't really happening a lot yet. A good example will be the midwifery whistleblowing incident, which we're going to take as a bit of a deep dive on the assurance of that in the involvement committee. So that's, if you like, a new flow. We don't have our subcommittees really clicking yet. So I think we're in the same state of just, learning how to do this. I'll mention a bit more later.
Okay, thank you, Alan. Okay, let's move on down the reports then, please, because we spent some time on that, but I think it's really important. Finance and workforce, Nick.
Thanks, Sheila. Morning, everybody. The apologies that I'm hoping you've all seen the more recent report that was updated yesterday afternoon. A couple of tables needed a tweak, so apologies that there was a late amendment to the finance and workforce report for this month. The paper that's in the pack is the correct one, though, and that reports that we have broken even for August and September as forecast. That's no great surprise given the way we've been funded for the first half of this year. As highlighted before, our concern is more on the second part of the year, and we've now had the guidance and the anticipated adjustment to our income for the second part of the year, which isn't as bad as we thought last time we met. The reduction in our income in the second part of the year will be about 1.7 million. Last time we met, we had early indications that number would be around double that. So that's relatively good news, but still gives us a challenge in the second part of the year of an enhancement to our cost improvement programme of around 1.7 million if we were to address that shortfall in income. At the moment, our forecast has remained the same, which is very prudent startation that we are assuming we won't achieve very much of that 1.7 as a SIP in the second part of this year. I'll come on to SIP a little more in a second, but the forecast at the moment does assume a worst case there, that we don't make much in the way of inroads to that additional challenge, as well as the challenges that we've already alluded to this morning around operational pressures through the winter and continued COVID unpredictability. So we've left the forecast as a 5 million deficit. I do think that's on the pessimistic side, but we've been asked to produce a new plan for the second half of the year for NHSE, and as we develop that plan over the coming 2 and 3 weeks, we may find that plan could be an improvement on the 5 million deficit, but for now we're still working to that for the purposes of today. So that's the forecast. We've also touched on the board report this month around the Electorate Recovery Fund, and that we are largely anticipating we could earn around £5 million through the ERF, but that it would cost most of that to deliver it. There might be a small margin in there that would help towards our increased challenge, but that's the ERF, and then SIP. So we've really tried to re-galvanise the organisation around the cost improvement programme, really stepping that up. It's difficult at the moment, as we've said. Operational pressures it's a tough time to be asking operational managers to be really focusing on SIP, but we have pushed that forward over the last few weeks. Each division now comes along to the executive on a Wednesday and has a half an hour slot. The first of those is this week. I'm actually on leave this week, so I wasn't at that meeting. Helen might be able to enhance on that in a second. But I know that the divisions are presenting their position or are discussing that with the execs, and I know that the one that met this week have put aside their next divisional board meeting purely to address their SIP challenge, and we anticipate the other divisions will do much the same. All really trying to gear up towards next year's SIP, probably more than delivering very much this year. The PMO have produced a model health system guide, which should give some opportunity to look at benchmarking. And we've also engaged a chap called Charles Simmons, who has been working across ESNEFT doing benchmarking between the Ipswich Hospital site and the Colchester site, to do the same benchmarking for us so that we can compare ourselves with both Colchester and Ipswich to look at what opportunities there may be there as well to deliver savings. So we've stepped up our SIP programme. I would say that the exec review meetings will certainly put some more rigour into that. as well as the work that John is doing with his team, that is an enhanced team now. I don't know if Helen wants to add to that at all, or any other questions.
I covered it very well, Nick. I think the only other thing I would say, we are really aware of the sensitivities around this at the moment and the pressure that people are working on. So the first step we did a couple of weeks ago was a joint communication from Nick and myself, but also from John as the head of PMO, McFarlane as the head of quality improvement. And we're really trying to nest the SIP programme in with the quality improvement in the organisation as well. And the other thing we've done is try to streamline the governance so that it is still robust and gives us what we need for assurance around the programme, but reduce some of the very big meetings with lots of people in that were time consuming and quite drawing on the organisation. So I think we're gradually introducing, and it's not coming as a surprise to people, these are all adults and they know that not just the organisation but the NHS and the country has got a huge financial challenge. We're just trying to not be overpowering with that and work that through.
Thanks, Helen.
Thank you, Helen. And I think you're right. I think everybody in the organisation knows it's going to be tough in lots of different ways, and this is one of them. I've got Craig and then Alan. Craig.
Thanks, Sheila, and thanks, Nick. And in particular, just a comment on the fact that we are working remotely has meant that Nick can do the board meeting from Southern Ireland. So thank you for interrupting your leave to do the board meeting. I suppose, as you said at the beginning, the year-end forecast feels like it's out of our control. So there will be some decisions that are taken in some room somewhere, which will determine what our income level will be, and that will then drive our bottom line. So in a way, there's so much of this is outside of our organisational control, which, from a board perspective, I'm therefore wondering whether we need to focus, or what we need to focus on. From what you've just been describing, it would feel like it's basically all about our responsibility to manage our expenditure position as well as we possibly can, whether that's through controls or whether it's through the cost improvement programme. And therefore, I'm wondering whether you can bring something back to future board meetings that provide that focus, so that we've got the ability to scrutinise and help develop the work that goes on, which is within our control.
So Craig, are you more looking for our run rate as much as anything, our expenditure rate, and what we're doing to try and improve that?
I suppose I'm asking for your judgment, and maybe it's you and Helen, to say that in a way the year-end forecast is not what we should be focusing on. It's about how do we ensure we're delivering value for money. How do we demonstrate that we are effectively stewarding the resources of the organisation? And I think from what you've just described, that's largely through the development of the CIP. That's how we will demonstrate value, and therefore I think that needs to be the focus of the board reports going forward.
Okay, and that can include the benchmarking work that we're doing as well. So
absolutely, that. Yeah.
That's
okay.
Really
You know, that I'd be happy to do that if other board members feel that's a better way forward.
I think that would be really helpful, Nick. I think it's a very appropriate way to tackle it. Alan, and then Chris.
Hey, Nick, I have huge sympathies for Alan. I was interested in the Simmons work with ESNEFT, and I wonder if there's a slightly bigger picture, an opportunity here, avoiding the inevitable politics of it. Is there room for some combined CIP thinking with our friends at ESNEFT whereby there might be some selected areas for an even greater progress, especially if you've got the same benchmarking methodology being used across the 3 sites. Should we be ambitious, board to board, if you like, and say, is there a bit of an initiative here to think, are there some opportunities for a sort of mega CIPs across all 3?
Can I just add to that? I mean, Nick, can you comment on where the finance managers group for the ICS is? Because I think it might be that there's some kind of synergy there.
Sorry, Sheila, do you mean the ICS Directors of Finance?
Yes.
We meet, yeah, so we meet each week and have been sharing our SIP plans going forward. That's where this benchmarking suggestion came from, that we use the consistent chap, Charles Simmons, so that we can absolutely compare like for like. I think when you use something like Model Hospital, it's so much broader, and whilst it can give some useful pointers, you can't have very specific conversations with other organisations about maybe what they're doing differently. And I think we can do that very well across the ICS on a sort of specialty by specialty basis quite easily. And I think that's the intention around this benchmark, is to have those conversations. I suppose it does lend itself to, if there are particular services that we might find we're particularly expensive at, and that we, for whatever reason, can't provide as cheaply as they can in ESNEF, do we have a wider conversation then around the most cost-effective place for some of these services to be provided? That's probably another conversation, but that's where we are. Certainly, I feel we're working very collaboratively with ESNEF in this. We feel like the scale of the financial challenge is collective. We are judged as a system now as much as we're judged individually. So we are trying to work together where we can, and that's where this has really come from, this benchmarking exercise. I don't know if that answers both your questions.
Partly answered, but in a way, could I throw the challenge back to you, perhaps as an executive team, to maybe ask that question about the other conversation? In other words, actually giving yourselves permission to actually challenge whether there are some areas across the piece where a bigger CIP could be met. I know it's painful and it feels competitive and there's politics, but I think, why don't we give ourselves that permission?
And I think that's a good question, Alan. And I don't know where we have those discussions on a service by service basis at the moment. I think when we've got the benchmarking, and that can open up the opportunity really for that conversation.
It's a good point. Thank you, Nick. And I'm going to move to Chris, and then we need to move on because we are running behind time. Chris, can I bring you in, and then I'm going to move to the operational report.
Okay, thanks very much, Sheila. And can I just say, support and applaud what Craig is suggesting. The reality is that after about 8 or 9 years of continuous cost improvement programs, the ability to squeeze much more out of what we're doing is severely constrained. Couple of very quick observations, and it feeds into what Alan is suggesting. The centrality of the role of the ICS, particularly once strategic commissioning goes in there and they have the entirety of the checkbook, means that they will be setting our targets and they need to start taking ownership of the performance. We don't want them in a position where we're being bashed by NHS improvement for not meeting some financial targets. And I think the quality of the engagement with ICS in terms of, if we're going to really change the financial dynamics of what we do, it means doing things differently in different ways and in different places. Actually, Colchester and Ipswich will have their own site constraints, their own resource constraints, just as much as we do. They'll be slightly different. Mercifully, they don't have RAC, we do. So actually just shifting stuff around the system may make sense from a specialisation, but it doesn't necessarily address the resource constraints. So I think, Sheila, and Nick, from your ICS involvement, we need to understand more about what is their strategic thinking about how and where services should be provided.
And I think that will be an ongoing discussion as we move forward with the development of the CS, and a very important one. Important to our patients, I hasten to add, which is the key thing. I'm going to move to the operational report, Helen, and we'll probably flow, I think, fairly naturally through your operational report into the IQPR, which is there for information. So Helen, so over to you.
Thank you very much, Sheila. Because somebody's typing. Mute. So I'm going to assume the report is read, but there are a few points just to call out. There's a lot of numbers in that first section around general and COVID activity. There are a couple there that are really, really unusually significant. So to see 155 patients in the month waiting in our emergency department for over 12 hours is shocking, is very concerning. Pre-COVID or even pre this summer, we wouldn't have seen that in a year, let alone a month. In fact, we were usually in single digits. So it is a horrible, horrible number to see written in a report, and is absolutely a reflective of pressures. Again, just to remind you again, although it's not formally reported yet, the nominal time that people should be in the emergency department is 200 minutes. We recorded 390 as an average for September. Again, two very concerning figures, and they do represent outflow from the department. They do not represent inefficiencies within the emergency department. They are a lack of capacity in the organisation. It would be understandable to think that that was related to our capacity closures due to rack plank. And whilst I don't have the exact figures for all the organisations around us, I can assure you they are seeing similar levels of performance. When I've or any of my colleagues have sought mutual aid and assistance when things have been particularly bad, all of the organisations around us are seeing a similar decline in their performance. The only good thing I would say is, and it's a double-edged sword, at West Suffolk we do still, for the majority of the time, manage to maintain good performance in ambulance handover delays, and that is the real risk to this. Once we've got ambulances queuing at the front door as well, that reflects people getting no help at all. We are very good at that particular metric, not to say we don't sometimes have delays. The double-edged sword to that is that often brings more to our front door because we can offload them quicker, but then we get stuck. The second set of numbers are the ones at the end of the next paragraph. So 198 patients over 7 days, 104 over 14 and 64 over 21. I mean, we will always have some of those, but our nominal performance metric, for example, for over 21 days is 39 patients. So huge numbers, which are reflective of the problems that Clem will talk more about in his integration report in terms of the availability of domiciliary care. We are working together as a system, and I'm going to leave Clem to talk a little more about that. But we are definitely being adversely affected now by that challenge. And I thought long and hard about that sentence to describe people as working in survival mode and whether that was over-egging it, but it's the reality, and our teams, and it's that piece that Alan was referring to before. And people do still come in every day and they do still want to do a good job. And we see lots and lots of examples of it, but they're also very tired and often distressed when the circumstance means they can't deliver the care that they want to deliver. And the 5 o'clock club and the move, the not move to, but the heightened awareness around compassionate leadership, I think, will be a critical factor in carrying the organisation forward. So the RAC Plank programme continues. I think most people are aware we did, as a result of those pressures, we halted the work on Ward F7, and we've opened F7 for a temporary period in order to manage some of the medically optimised patients waiting for ongoing packages of care at home. And that area is currently full. We've got a challenge coming up as we do need to close that by the 1st of November in order to hand it back to the contractor. And again, you will see in Clem's report and further in this report just how we're trying to mitigate and manage that. The paediatric ward is due to move back next week to its home. They've done incredibly well on G10 and have managed their service with, I think I'd like to just formally at this point put on record our thanks to colleagues at Addenbrooke's who have particularly supported paediatrics during this period of time, as we have had a significant reduction in the side rooms able to look and care for our neutropenic children. And I think Craig is specifically going to write on behalf of the organisation to thank them for that. If I just move you then on to the winter plan, I don't propose to go through the detail here, although I'm happy to answer questions. The thing I want to draw out of this is that you could be forgiven for looking at all of those months on that table that say we've got sufficient beds and thinking this is a good news story and thinking this is all very positive and we're all going to be okay. I think what we have to realise is these are average numbers based on average modelling of the last 2 years. The last 2 years has been very unprecedented, so the modelling to some extent is slightly questionable. There are lots of unknowns. What will the COVID level look like? What will the emergency demand look like? And because of the way in which we are working, we have lost any flex that we have in the system. So our ability to deal with peaks and troughs in activity has been eroded at the moment as a result of the decamp programme. So I'm just going to give you a little vignette, because yesterday evening as I left, I thought the organisation was looking in a good place, and I thought we would come in a good place this morning. And before starting the board meeting, I'm actually based in a different office this morning, right next door to the control centre. So I popped my head in and said, okay, what happened? Because we're not in as good a place, not in a critical way, in a curious way, let me be clear. And the guy said, we admitted 15 patients above the number predicted the day before yesterday, and we admitted another 7 overnight last night. And our plans are so tight to the wire, we haven't got the resilience to cope, and that's what's pushing huge pressure on the teams. But they are coping just about, and I think we just need to be really supportive and mindful of that. Just towards the bottom of this page, I'm on page 58 of Convene, we have procured with the system using some of the ongoing but not recurrent discharge funding. We've procured 45 community beds, which will enable us to change the use of the Newmarket community beds over the winter. The plan behind that is really to mitigate the loss of our winter escalation ward on the site here. So we will base a junior doctor out there, we'll put some additional staffing. These patients will be stable and medically optimised, but they may require just a little bit more ongoing care than we normally would. We have managed to find the additional community beds and we are starting to use them. And the next section, and you could almost be forgiven this, and I've deliberately included quite a lot of detail here, because there's a real juxtaposition between what I've just described and the planning guidance that then has an awful lot of challenges of things that we are expected to deliver. We're expected, number one, to support and look after the health and well-being of our staff, at the same time pushing for the delivery of an awful lot of priorities. None of those priorities could we question. They are all reasonable, appropriate things we need to do. However, as a board and as a leadership team, we, or should I say you, will need to be very careful about the balance here. There is a real focus around getting to March 2022 with no patients waiting over 104 weeks for elective procedures. Now, again, pre-pandemic, half of that waiting time was considered to be unacceptable. So there has been a real shift. We are doing a tremendous amount of work, and this is a real example of how we've moved forward in our relationships with ESNEFT as well, because in orthopedics and in gynecology, certain subset of gynecology, there is no way we will achieve that on this site given our capacity issues. And we're looking at that, therefore, as a system and making arrangements to transfer a cohort of patients who are prepared to go to have their procedures at ESNEFT, at Ipswich or Colchester, whichever, undertaken by their teams and looked after by their teams. That will undoubtedly worsen their position from what it might be, but overall, across the system, we are trying to be equitable and balance out that waiting time. Some of the other things we've talked about: advice and guidance, patient-initiated follow-up, virtual attendance. They've all been in the guidance before. None of those things change, and we continue to work hard to deliver on all of those. But the balance between these elective challenges and the significant pressure on urgency and emergency workflow and the rack plank lead this to be an incredibly challenging winter as we move forward. I think I'm going to stop there, Sheila. I am happy to take any questions. Sorry, that was such a, I feel as if I've just, set a real challenge.
I think it's appropriate at this meeting you do, Helen, because the challenge is for others to pick up. But thank you for your report, as ever, incredibly detailed, but totally focused to the point. And it's a very right challenge to leave us with. And I'll say more of that later, several times probably. I'm going to come to Craig, and then to Louisa, and then to Richard. Craig.
Thanks, Sheila, and thank you, Helen. I suppose that my point is going to relate to your last comments, Helen, and I think it's what I think we should be doing as a board. So yesterday, it's amazing what you do as chief exec. I had a meeting with an ex-MP about levelling up goals. horrible phrase. I suppose at least they're using 2-word phrases rather than the normal crass 3-word ones. But all of the stuff was really noble. And they're talking about a programme that every trust is going to have to go through, where we measure our progress against levelling up goals, which is how involved are we with education providers. All of it is great, and everybody would agree with it all. What I said was that I think it's mine and our responsibility to do exactly what Helen has just described and prioritise. We can't do all of this. Helen's highlighted all of those goals. We won't achieve them all. And actually, I think we need to have the debate about what don't we do, because that's far more important to the people in the organisation than, to be honest, what are we going to aim for? It's what don't we do? Those are the really difficult questions, because exactly as Helen said, you can't disagree with any of the stuff that's in the operational guidance. However, it is not all achievable, and we need to provide that leadership. And I think that's a debate. I recognise there could be a reasonable criticism that says we need to provide recommendations so that we can debate. But actually, I think we're at the stage where we can have a board debate about what those priorities should be.
Thank you, Craig, and I think you're absolutely right on that. Richard. Oh, sorry, Louisa first and then Richard.
Helen, sorry, I've got a really bad sore throat, so I hope you can hear me. Helen, thanks for the report. Craig, I agree with you about prioritising and the rationale behind it. I think that's really important that we do have that debate as a board. But I think Helen's used the term sort of survival to you as the exec, and it's going to be a tough few months getting to March 2020. So really, with the changes that we've seen amongst the execs, it's really, perhaps it's a rhetorical question or comment really. It's, please make sure that you have the resilience and the sort of, consider your own well-being, and you've got the sort of capacity and headspace to actually deliver some of this, because the last thing any of us needs, including the patients in the community, is one of you to sort of fail. So I think it's really important that we look at our staff, but that does include you.
Thank you for that, Louisa, and you're absolutely right. Richard.
Thank you. Yes, it's about the winter planning, and the modelling for the past couple of years, I think, has been extraordinarily good and accurate, astonishingly so. But you've already raised telling the horrible uncertainties this year. And I'm just wondering to what extent it's possible to make any sort of provisional thoughts, ideas, plans, plan Bs about the worst case scenario. If things go really pear-shaped, as they may just do, is there anything that we can do at this stage to begin to think about that, so we're not on panic mode?
There are some things, and there are actually, Richard, there are some regional and national conversations that are going on at the moment that in the last Chief Operating Officer weekly meetings have been described as the unthinkable. Now, they're not unthinkable because we've all thought about them, but they are the tough things to do. So things like appointment only attendance at the emergency department, for example. But that carries significant risk as well. And you can't just turn people away, you need to turn them to an alternative pathway. And as you more than most know, colleagues in primary care, despite the media, are also working flat out. So there are some challenges around that. You'll notice in the planning guidance, the protection of elective cohorts of beds is in there. And again, when I talk to the regional and the national team, they're very, very aware that is probably one of the aspirational things. Their comment is, if you never even designate them, then you'll definitely never protect them. And I think that's absolutely true. So we do have areas that are designated, but at the end of the day, we have to manage the most urgent clinical risk in those circumstances, and that's the emergency pathway, sadly, not the longest waiting patient. So there would be work happening in that way. We've also worked, and Sue's front and centre in my screen at the moment, because I know this would be a massive challenge from a staffing point of view, but we have very carefully designed the decamp programme over the Christmas period to make sure we don't have 2 wards that have got contractors in that are half completed with nothing happening during the closure, the construction industry closure period. It is certainly not part of the plan to go into those areas, but we've also been mindful that that would be physical capacity. We would then be pulling specialist nurses, pulling anybody with a nursing qualification that's working in a non-nursing role. We'd be doing a whole range of things, but we would have at least created the physical capacity. There was a discussion yesterday around what to you and I are called tents, and in the world of NHSEI is now being described as temporary demountable constructions, which I thought was interesting terminology for tent, which sites are being asked to look at siting in order to cohort patients who are awaiting admission or whatever. I'm not sure we've got anywhere we would put one. There is certainly one up at a hospital already not too far from here. So people are really thinking about what those things look like. And also lots and lots of thought is going into how we effectively communicate with the public around expectations and around what they can do to help themselves and to support self-care, because we are open, but we need to be open for those who urgently need our care. And so lots of thought going into local, regional and national campaigns around public expectation.
Thank you, really thorough.
And thank you for the question, Richard. I think, there are several things we need to hold from there. I think Craig is absolutely right. We need a board discussion on what don't we do, because that's the realistic discussion that is important to have for us and for our staff. I think we need to bear in mind too, as Jeremy has put in the chat, this is about care itself. We need to care for ourselves. We need to care for each other. We are a team, and we need to make sure we've got the level of care right in our team, as we are the role models for the rest of the organisation. And we need to focus on the rest of the organisation, but we mustn't forget ourselves either. And I think the other key message, and we've had this discussion at Governors, is around public expectation and how we manage that. And I know Helen and the communications department are working on that. So I'm going to, Helen, Sue, do you want to highlight anything from the IQPR? No. Sue, was there anything you wanted to highlight?
Yes, please, Sheila. I just wanted to refer to the complaints section around the gynecology, patients and maternity, and to acknowledge this is quite an unusual sort of picture for gynae and for maternity, and just to say that the complaints around the gynae teams were two complaints for patients coming in with management of miscarriage and are being investigated through our complaints team. Just to know, and I think the maternity complaints were just a reflection of the pressure, the huge pressure the teams have been under over the last couple of months. But having said that, it was an increase in August and September, but since the feedback's been discussed with the staff, the complaints have decreased, and we've only had one complaint received within women's and children's in September, compared to 8 in August. So I think that's good. But we continue to focus on what we can do to help support our patients and make sure they have the experience that they absolutely deserve to have.
Thank you, Sue, because obviously it's a very vulnerable time, so it's really important we get that right. Okay, thank you. If there are no other questions from that, I'll apologise for the poor chairmanship because we are running half an hour late, but I still intend, I think for your health, apart from anything else, we will take that break and let you go and get a cup of coffee. Okay, so 10 minutes, absolutely on the dot of 10 past, please. We'll have you back. Just turn your cameras and microphones off. If you come out, you might never get in again. starting. Can we run down to the Improvement Committee, please? And Jude, the most important committee of all, I hasten to add, rather than only.
Thank you, Sheila. Right, as I said earlier, I wanted to share some reflection. First committee that I chaired, and I've already shared the first of those on flow of information and importance. Before I forget to, I'd just like to offer my thanks to Sue, who's helping me to navigate the plethora of committees, subcommittees, and various sources of information. So I'm learning, hopefully learning fast, but I need a lot of help, and Sue's been incredibly helpful in getting me somewhere up to speed. The second reflection I really wanted to share was on, I think, a point you raised, Sheila, about pace. Coming back to the point I made earlier, that essentially what we're looking at the moment in Improvement Committee are existing issues, legacy issues, if you like. In most part, there are already detailed plans in place, improvement plans, action plans, and in large part, the majority of those actions have been completed. In one or two cases, there's still some outstanding work. And I think the focus of the committee, and I think we had some very good discussion, was on ensuring that the final activities were completed as quickly as possible. In many cases, the actions you see highlighted in my report will be reviewed again. The groups responsible for those actions will be brought back to the committee. I think we've tabled several of them to come back in December to ensure that progress has been made. In one or two cases, the action has been identified as even more urgent, and the one I'd like to highlight is the action around out of hours deteriorating patients. The deteriorating patient group had identified the need for additional resource in, I think, critical care and surgery. And initially, I think they were coming to the Improvement Committee to get approval to go out and hire staff. We made it clear that there was a proper or a different process to follow. That has now been followed. And as I understand it, and Nick's nodding away, the business case has been made. I'm not sure whether approval has been granted for the additional staff, but maybe, Nick, you can just give us a quick update on that.
Thanks, Judy. Around critical care, we did approve that business case about a month ago now, so that came through the new business case approval process. What was the other one there, Jude?
Well, they were both. Well, surgery, I think, was the other area.
So I'm not sure whether that's been approved or not. Well, but anyway, critical care certainly was.
Okay, but the point being that there was a need for swift action. The issue was linked to some SIs, so clearly there was an element of patient safety involved, and the committee, I think, were assured that movement would take place rapidly on this. I see both Helen and Sue with their hands up. Sue, I think you were first.
Yeah, it was just to clarify. I think the business case you're referring to, Jude, with regards to the critical care outreach team rather than critical care itself, and that business case is still being worked through with Julie. I had a conversation with her a couple of weeks ago, so that's still in progress as we speak, but we are reviewing as part of the winter plan how we might be able to support and increase the level of critical care out of hours, so that we will be doing that through the winter plan while we simultaneously work through a business case to potentially increase the capacity of the team themselves.
Okay, thank you.
Apologies for me.
No, that's all right. Helen, I guess you were going to make the same point.
So I was going to make the same point around that, and the other point is it's, if you like, it's a subset of surgery, so it's gynecology, and it's the junior doctor tier for gynecology that, again, the team are actively working through, but Ravi needed to do some work across the consultant levels before being able to understand what the gap was. But to assure everybody, I have followed up both of those from the Improvement Committee to say, can I have a progress update? Can you tell us when these will be ready to come through for consideration? So they're on the radar, as it were.
Okay, very good.
Thank you, Helen.
Right. The other point I just wanted to raise was just in the wider system of how our governance structure is working, because there will be external developments which will challenge us in terms of how we respond to that. And I just want to pick up item 5.1, where the committee was informed of a new CQC assessment framework, and it was felt that this would require us to do some self-assessment to understand how well we're performing against that framework. So the challenge is, well, I guess it's several challenges. First of all, who should do that? Which group? How would that, or how should that report into our governance structure? And I think Anne kindly agreed to take that one away to have a look at. But it's just an example of where we've got to move very rapidly as the external environment changes, and we've got to make sure that our governance structure can react to that and is fit for purpose. That's all I wanted to say. I'm happy to take any questions.
Thank you, Jude, and thank you for the very clear report. I think you're right externally, and I mean, if you look at CQC and the way they're looking at system working, where we sit in the system, there's some really interesting stuff, but some challenging stuff for us to take on board and work with going forward. And thank you, Anne, for taking that one away. That's an interesting challenge as well. I haven't got any questions, and I think we had the wider discussion on the way the committees work and the way that some of the generalities, but also some of the interaction between the committees and how those flows of information work we've covered earlier. I'll take Alan, and then I'm going to move to maternity.
At that point, really, Sheila, one of the issues in the involvement committee is that any change we make ideally should have involvement and engagement at least considered. And I'm wondering whether that's something we could throw back to Jude and the team, which is to say that almost as a standard item, when improvements are being made that you are getting assurance on, that you take that into account. In other words, one of your tests of assurance could be or should be, has sufficient engagement taken place with the staff or patients who are affected by this improvement? And I'm wondering if that's something you'd like to think about, Jude, as a kind of natural process step when you're signing off your assurance, if you like, for any significant changes.
Yeah, that's a really good point, Alan. I mean, I think we've discussed it more in terms of if there are changes to processes involved in the improvement work, how can we be assured that those processes are now embedded in the organisation? I think there's a crossover there, but I think we'll have a think about your point as well. But we're certainly looking at the assurance we can get about embedded processes.
Thank you, Jude. I'm going to take Chris. I will take Chris, and then we will move on to maternity. Chris.
Great. Thank you very much indeed, Sheila. And Jude, thank you very much indeed for your presentation and the issues you've raised. I suppose just want to reflect that for everybody that this report format is still very much a work in progress. I think the wider context is important. One of the things I think we need to be thinking about is those issues, and you mentioned CQC and the wider assurance and peer assessment and so forth, that you particularly in terms of improvement are bringing to the board. How do we evidence the detail in the report or the links to the detail that then enable us to have an informed strategic debate within the board space? And I suppose, what we said earlier on about links back to the BAF register, key documents that we might be wanting to consider to inform that debate as part of our preparation, all of that. So great start, but more work to do, I think.
Thank you, Chris. I think you're right. There's a great deal more work to do. I'm going to leave that one there. Straight to maternity. And Karen, I'm sorry we've kept you waiting. I do apologise. But we're ready to hear from you now.
Can I just step in, Sheila, just before Karen starts, and just to say, you'll see appended to Karen's Karen's papers an overview of the whistleblowing incident and some of the actions that we've already taken, and mindful that the paper does read a little bit transactional in so much as these are the actions we've taken, but this was to demonstrate to staff that we had heard some of the things they suggested. It is the very start of a much bigger, longer piece of work with involvement and supporting staff going forward. And I know that the Involvement Committee are going to take this part as part of an organisational piece of work as well. So to acknowledge, thank you to the team for providing the update, acknowledge that it does read a little bit sort of transactional at the moment, but it was really more that we can demonstrate you said we did, and we will continue to work through the Involvement Committee and with the teams to ensure the staff feel that they have been listened to and that they feel we're taking the right and appropriate steps to help support them.
Thank you, Sue. That's really important. Karen, I'll hand over to you now before I say any more.
Thank you very much. The Maternity Quality and Safety Performance Report has been prepared by myself. It was a joint double act this month, and I will take it obviously that it was read. The things I wanted just to highlight, I'm very excited by is e-care. Not obviously that it's in this paper. Up until September we did have about a 2-month delay, but we already have September stats, and that's by the second week in October. So I'm like, oh my goodness, so we've really got forward with that, and our digital midwife has now started, so that is all fantastic. So I'm hoping that there will be a that will be ongoing now, so that's really great. Safety Champion walkabout, there were 3 walkabouts in the last kind of report, so only one walkabout in this for this regarding the neonatal unit, because obviously that's are the areas that Paul covers. Just be aware really of the staff satisfaction survey, so that the maternity one on the back of the whistleblowing episode has now been completed, and we are now working through and amalgamating the answers, and again so we can kind of demonstrate the action that we've taken on the back of that. I think, well, Paul was very excited because we've had really good feedback, levels of people who've completed it, so that is really great. And obviously when we have collated all of that information, we will feed that back through this forum. And then the other 2, just the maternity dashboards, quality dashboards and clinical dashboards really represent how it is regarding staffing in maternity. No real change from the last couple of months, just with the number of short staffing, that obviously that does then impact on the appraisals and also the daily checks, those kind of things, but we're not very much high on our priority. It just seems to be, particularly with the daily checks, it tends to be at the weekends when there is less management around that they are dipping, but we're still very high on our priority and we're trying to resolve. And then just the 2 or one of the papers that is the attachment Annex B is the NHS England summer workforce concerns. So this was a plan that was devised from the regional team to actually support trust in actually just giving us help in what we should be doing with the staff shortages. As you can see from that, we have completed all of the actions that was required there, so that was good. And the 8-point maternity neonatal service action national response to the staff in midwifery crisis. They also did include the COVID-19 side of things, and the only action that was incomplete was regarding the COVID vaccinations in antenatal clinic, and I'm again very excited that they will be starting. We're just waiting for SOPs to be signed off there. It will not be a long-term thing because obviously we don't know what the take-up will be like, and we're only dependent on how much COVID vaccination that the trust has, but it's really important that we are offering that in the actual place where women are, rather than asking them to go elsewhere. So that is that. Has anyone got any questions?
Thank you, Karen, and thank you for so briefly summing up an awful lot of material. And we do recognise just how difficult it is, and you know, there's been so much on the national news about lack of midwives and the whole understaffing issue, and we do recognise that just makes life incredibly difficult for you and your colleagues, and it must be a daily grind, you know, of what the levels of staffing are like. So we really do recognise how hard you're working to mitigate something that is outside your control and to a great extent is outside ours. Craig.
Karen, thank you for that. You won't have been here, but we had a discussion earlier on about the need to prioritise, and I just wanted to, I think, highlight to the rest of the board that this is a perfect example of a department that is trying to do more than it ever possibly could achieve. So the bits where you're talking about the daily checks, the appraisal and so on, that on top of everything else you're trying to achieve means that you're being asked for the impossible. And I think we all as an organisation need to work together to find out what we don't do and agree what we can't do, because the pressure that we're placing on individuals is huge. So I just wanted to make that point. My other question was about vaccines, and we know obviously there were the issues of the uncertainty around vaccinations in pregnant women. I am aware from a regional perspective some of the anti-vax activity that has been happening. We also know that there's a disproportionate number of pregnant women that are in hospital with COVID at the moment because they're overrepresented in the population that are unvaccinated. Have you had any experience within the department of that anti-vax activity?
I think at the beginning, lots of people didn't know really what the effects were going to be on unborn babies. And I think so that's why not necessarily anti-vax, but not actually actively saying, yes, we recommend that you have the vaccination. I think since it has come out that, yes, we should be actively saying, yes, you can have the vaccination. We have done a massive drive with midwives, with the consultants on our social media, really making sure that everybody is aware of that. So not just the women, but actually professionals as well, that, you know, we can say to people, you can have the vaccination. So I haven't had the experience of people being anti-vax at all. I still do think there is a majority of women who do not want to have the vaccination until they've had the baby. However, our own kind of staff group who've had babies, pretty much all of them have had the vaccination. So that's really good. So it means we're getting across to some people. So that's good.
Brilliant. Thanks, Karen.
Thank you, Karen. Louisa.
Karen, thanks for the report, and it really sort of complements something that Craig has said around what we don't do. I know that fixing the sort of staffing is not easy and is challenging, it's not going to be dealt with quickly, but can you provide us with some assurance that you've now got the administrative support, ward clerks, data inputters that you need to service these phenomenal reports, which then will potentially free up you know, the really skilled staff to actually deliver the service?
Yes, and we have started the recruitment process, but obviously that takes time. People have to hand the notice in and start and checks and everything. So yes, we have gone out for advert for all of those posts, and yes, as soon as they come through, they will be in post. So yes, that has been taken. That has really gone down positively with all staff, because actually admin side of things does really help, especially with e-care. So yeah.
Thank you. Good question, Louisa. Richard, I was going to come to you anyway as maternity champion, but I'll bring you in now.
Thank you. Yes, it was another question about staffing, actually, which is I know the pressures on midwifery staffing. You talk about in the Attain report the neonatal unit staffing and the need to increase the number of neonatal unit staff, particularly to help with the transitional care unit and improve the unnecessary admission to the neonatal unit. So 2 questions really. One is, is neonatal unit staffing as challenged as midwifery staffing in terms of recruitment? Are there people out there? And secondly, are you getting all the support you need from board and from the organisation to help to recruit those people? It seems to me an important area.
Yes, so the neonatal units, I'm less familiar with their kinds of staff being out there. However, we're not talking big numbers, and I absolutely think we've got really good people recognise that we're a very, very good unit. Our neonatal unit is held in very high esteem, so I do not see that being an issue whatsoever of us being able to recruit to the neonatal unit. I think with the Attain, one of the big issues is, again, with babies being admitted, is you can see that quite a few of them are sometimes still cold, and I think that doesn't help when we're moving from theatre to theatre, because everyone knows we've got to have the theatre quite warm, and that doesn't that's one of the issues as well. But again, the roof work and everything else, we will go where we are told to, so that's absolutely fine, and we will overcome these issues. But I do not think we won't have an issue recruitment, and it is very much on our agenda. Yes, so just so that you're aware that now that Justina is in post as the deputy head of midwifery, she is now going to take more of oversight of the neonatal unit, just because they work very, very closely with maternity, and it's now about bringing the two areas together. So because we're all striving at the end of the day for the same thing, and we want to be making sure that our babies are as well as they possibly can, just having that really good communication and working relationships with our neonatal unit.
Thank you. Can I just ask one supplementary question as well, which leads on a bit, I think, from Liz's question at the outset, and about the whistleblower. I know that you have put an enormous amount of work into helping morale amongst the midwives, communication, walkabouts, all the action plans and so on. And I know it's early days and it's going to take a long time to turn things around, but I just wondered if you've got any sort of gestalt feel about how midwifery staff are feeling in relation to the efforts that you've been making and to improve things. Are people content, do you think, that they're being listened to?
I think they feel that they're being listened to, but it doesn't change the end result, and I think that's the frustration with everybody. And so now I am trying to, with the staff, and I do go around at least 3 times a day to every area, speak to every member of staff, and it's very much now about, actually, we can't see it's going to be fixed in the short term. This is a long-term thing, because it doesn't matter how many staff. So the majority of shifts now, because of the uplift that we have in place, are pretty much covered. But if 4 people then go off because their children have got positive lateral flows, I can't do anything about that, nor can they. So that is where their frustration is, and that's not going to change. So yes, I do think they do know that they are being listened to, and we are sharing everything that we possibly do. I think we've still got masses of work to do, and I think it's just now the long term of it all. But that's going to be across the whole trust. Everybody's going to be in exactly the same boat. The neonatal in exactly the same boat. We're all absolutely fine until, as I said, you get people coming who've got their children going off with the positive lateral flows, and then it takes an impact on everybody.
Thank you.
And I suppose the challenge for us is, how do we support people through that interim period until we hopefully can recruit more people, we can change things on the ground. And that's a challenge for us in terms of not just listening, but demonstrating care. Do I have any? Sue?
I think, just to reiterate that, Sheila, the issue that we have, and everyone across the system have, not just us in our trust, is that none of our systems run with any flex. So we don't run with spare staff. Wouldn't that be lovely? For me, probably not for finance, but we don't run with spare staff. So any slight knock to the system has quite a big impact, and I think Helen will reiterate that from an operational perspective. What we find is that it doesn't take very much to tip us over the other side of the balance, so we just need to be mindful of that and be ready for it.
Yes, we do. We are stretching everybody and the whole system extraordinarily thin. Okay, thank you. I haven't got any other questions. Karen, can I thank you personally, and can I thank your teams? We do know how hard it is for them, and if we could produce more midwives, preferably experienced midwives overnight, we would. But in the meantime, we will try and make sure that we are giving as much compassionate care as we can to you, to the teams, and it's really important that you and others look after yourselves, because you are so important, and so important at the end of it to patients and babies, you know, and that's, we come in to care for people, to care for patients, babies, the elderly, all of them. So thank you.
Thank you.
Thank you, Karen. And so we'll now move to a rather more prosaic, although just as important, and that's infection prevention and control.
Yes, so I won't labour too much on this paper in the interest of time. I think it's important to note that we are seeing increasing numbers of patients with COVID positive coming into the hospital and also requiring critical care. And I know that yesterday we reported 2 COVID positive deaths. So we are seeing an impact and we continue to monitor it. We are really focusing on the proactive screening swabs and making sure these are done in a timely fashion across the organisation, so that we can make sure that our patients are placed in the appropriate places. And at the moment we are managing within our current capacity, agreed COVID capacity, but it is always on a day-by-day basis that we're looking at it. I'm happy to take, we are also continuing to focus on the VRE outbreak across F6 and surgical areas, and we're making progress on that. With regards to the COVID-19 learning, we are pulling together a paper that will come to board in December, where we will hopefully have captured all of our learning through the COVID outbreaks that we had earlier on in the year, to try and prevent this from happening again. Part of the paper has got the learning collated, but what we haven't done is been able to contextualise that to each separate outbreak. So we're currently working through that level of detail. I'm happy to take any questions.
Thank you, Sue. Just a comment. I think the learning report will be really valuable and interesting, but it's one part of the learning, I would have said, for the organisation and for the system that we need to work on as we move forward.
Indeed.
Are there any questions or comments? In which case, thank you, Sue. Thank you for that. And we'll move straight on to the nurse staffing report. And Dan, I think you're with us.
Hi there. Hi, and once again, thanks to the board for having me to present our nurse staffing report for August of this year. As you know, I like to be glass half full, but it's been a challenge to be glass half full with staffing over this period. I think we've seen a second month of quite a significant challenge within the nursing workforce. The context of this paper is obviously within the school summer holidays, where we have a known reduction in temporary fill of bank and agency staff, compounded with an increased sickness rate and an increased isolation rate, which has been documented within the paper. That is obviously reflected in our fill rates, and you'll see fill rates for this month have been probably one of the lowest I've seen, I think, in the organisation since I've been here, in the first chart on page 2. The positive being that hasn't translated in any decrease in patient care. We can see that both pressure ulcers and falls have maintained a positive trajectory downward. So although there has been significant challenges, they haven't translated into quality. Just again, picking out some of the highlights before I quickly take questions. Again, we've seen a slight decrease in our vacancy rate for RNs within the inpatient setting, And you'll see on chart 4, our actual substantive numbers within the organisation as a whole has maintained relatively static. I'll pause there for questions.
Thank you, Dan. Are there any questions at this point? Craig and then Sue.
Thanks, Dan. I just want to pick up your point about the fill rate, and there's your point about low fill rate not associated with an increase in incidence, and I just want to understand the sort of prioritization that goes on. It's obvious that when there is an individual shift that is down on staffing, that you can prioritize in terms of some of the things you might do that you can put off till tomorrow. And over a slightly longer term, there are things like appraisals and training that you can delay and maybe put off a month or so. And actually, those are things that mean we can manage not to see incidence rise, but its activity is not sustainable, and that there may be a delay between incidents coming through on the back of staffing, but it's inevitable that they will. I just want, is that your understanding as well?
Absolutely, if there's instances or a trend in that for it's an over time thing. If there was a significant drop or increase on a month standalone, I wouldn't necessarily equate that to a trend. I think also the commentary around fill rate has to be in the context of our vacancy rate too. So as you know, from April we had an uplift to a number of areas and skill mix change. So actually a lower fill rate this month might have been a favourable fill rate in March prior to those uplifts going in. As the wards still try and recruit into those areas, there is still technically a shortfall, but may not be the shortfall that we would have contextually realised in March. Does that make sense? Yes. So although the numbers are showing a decrease, we do have to put that into context as well, in understanding what's happened over the last 6 months.
Thank you, Dan. Sue.
Yeah, thank you, Sheila, and thank you, Dan. As always, a very robust paper. I think what I just wanted to bring to the attention of everybody is the fact that, and it's on the basis of listening to staff. So I have had a number of staff that have come to me to say they're concerned about the number of times their staff are being moved, about how we're managing the balance of risk across the organisation, and indeed some areas that have actually been very concerned to the point where we've called a risk summit for them. So we've now had 2 risk summits, one for F6 and one for critical care, which was yesterday, so that we can review that quality data over a period of time. We can and that includes all of the KPIs and staff sickness and appraisals and things that we measure on a regular basis. And I've also had some one-to-one conversations with ward managers and their matrons to sort of just hear exactly how the staff feel. So we are sort of reaching out, but we are constantly looking at ways we can improve how we articulate decision making, how we support those that are making those decisions, and how we remain compassionate in the decisions and the way we speak to staff, because I think sometimes it's the language that we use and being able to articulate a broader view of what's going on rather than just what's going on within each area. But we are mindful that our staff, particularly overnight, are feeling very, very vulnerable at the moment. And so there is work ongoing with myself, the heads of nursing, Dan, and the matrons to look at what additional support we can put in for those staff to make sure that they feel that they are supported, especially out of hours, because we do know that at that time, out of hours is our most vulnerable time for our staff and for our patients.
Alan, can I bring you in? Do I make any comment?
Hi, Dan. Your modelling over the last year or so has obviously begun to bed down now, which is great. A couple of questions. Firstly, as I mentioned to you offline, does it work for the midwifery area? Does the same principles apply? And is it consistent with what we're hearing from Karen and the staff there? And secondly, can your modelling be applied in any way to our community staffing, so that we have assurance about the recognised levels of safe staffing there that we should have?
So I'll take the maternity point first. No, the modelling doesn't match in maternity. Maternity have a very unique way to the adult inpatient area as to how they manage their staffing establishments, and that's Birth Rate Plus. That's a national recognised tool that you'll probably be familiar with that looks at the midwifery landscape across both community and acute antenatal postnatal care, and comes up with a recommended whole time equivalent. That's the expectation there is that it's completed every 3 years, and we're due to have our next cycle next year. However, our midwifery team haven't remained static within that, and they have increased their staffing to recognise the changes within the LMNS over the last 2 years, particularly around increasing their specialist midwives and also to recognise the impact of continuity of carer. So it is a very different model, and it has its own bespoke way of measuring. And like I say, we are technically in date, but I don't think we have sat on our laurels and not responded to the changes in the pressures within the service. And the second point, you'll have to refresh me because my answer was too long.
It was really whether the same modelling or a variant of it be used to see whether our community staffing is at the right levels.
Again, it's very difficult to translate, and they have their own tool again, which is yet to remain, yet to see the output of, and that's the Benson model, which is currently being worked through. The tool that we use for the inpatient, or which is you'll remember as the Safer Nursing Care tool, which is run and comes out of NHSI and E, they are actually doing a pilot within the community for a similar model. And that's currently within the Ipswich system, I believe, in the pilot stage, but again, haven't seen the output of it yet. But it is a different way of managing staffing establishments. But certainly we've adapted it for our CAB beds and for our community inpatient beds, using our own professional judgment on it. So there are times when you can use a little bit of ingenuity, but certainly for the community healthcare teams, it's very difficult to do that.
Can I just come in on the community one, just to add a little bit more flavour? So we've had to put some building blocks in place for our community teams, because until recently they weren't on the electronic health roster, so we didn't really have the visibility of how many staff we'd got anyway. Then, as Dan said, the modelling tool is very, very different. We've now run the Benson modelling a couple of times and are using it, and actually recently the community team presented to execs, and they used the output of the Benson modelling to plus their activity data to very successfully persuade us of an increase in their establishments. And actually they'd done a really good job using that data, and I think that's the first time we'd been able to see that for community, which was really positive. And the final piece of their jigsaw puzzle is an automatic scheduling system called Malenko, and that will take their activity, their shift profile and their actual appointments, and we literally start the rollout of that system in one of the community teams in November, and then over the course of the next few months we'll bring all the other teams online, and we really truly will have a proper picture for the first time ever of the pressures within community.
Thank you, Helen, that's really helpful. Okay, Jude.
Yes, Sue, just coming back to the point about staff feedback on fill rates. I mean, I can understand where if fill rates are below or well below establishment, I can get that. But is there any evidence that staff are concerned about the establishment itself? Are there cases where fill rates close to establishment are leading to staff complaints or concerns?
Well, I'm sure Dan's going to come in on that. Actually, he just popped his hand up, so I'll let Dan articulate that as he's here.
Dan. I think the challenge is that because we have seen quite unintended and short notice shortfalls that we've experienced, as Karen articulated, around staff isolation and increase in sicknesses, plus the recruitment still rolling to get into the uplifts, I think the staff haven't really experienced what the uplifts feel like yet. Because when they do get to their full establishment, staff are often moved to support an area that is underfilled. And I had an interesting conversation with one of the ward sisters recently who said that when she has had her uplift numbers, she feels that's what she needs and that's what suits her needs and her patients' needs. But I think at the moment we have minimal opportunities to really assess that from a kind of qualitative point of view and how it feels to the staff.
And I know that the moving of staff is such a sore subject for them and for the ward managers as well. Sorry.
So just on that point, and it's not in the board paper, but it is a relatively new initiative. And I will elaborate further in next month's paper. This month we launched our rapid response pool, which is a pool of nurses or nursing assistants that can book into a temporary shift with the no knowledge that they will be asked to work somewhere within the trust that is experiencing a staffing shortfall, and we will reward them financially for that pre-planned flexibility. So the essence of that is that we will hopefully be able to move less staff around who thought they were working on a certain ward but ended up working on another. It's only in its infancy. It's only 2 weeks in, but we are seeing uptake.
That's a great idea, because we know that individuals vary in their ability to deal with flexing and working in different ways. So that's a really great response. Okay, if there's no more questions, Dan, can I thank you for this? It's a fabulous report as ever. It really gives us a detailed picture of where we are in terms of staffing. And clearly at the moment it's pretty tough out there. So thank you. And more importantly, we should say thank you to the staff, because they're the ones who are stretching and flexing and working in ways that perhaps they wouldn't choose to work. So thank you for that.
Thank you, Sheila.
Thank them for that. Okay, quality and learning report. Sue, was there anything you wanted to highlight from that report?
No, I'm happy to take it as read. Well, yes, there's one thing I just wanted to highlight. I'll take it as read. The first incident that you'll remember we declared as an abundance of caution a never event relating to an epidural and IV connection. We have now finished that investigation, and during that investigation and with the discussion with our CCG, we have now downgraded that and it has no longer been reported as a never event. So I just wanted the board to be aware of that.
Thank you very much. So, Alan, I can see there's a question.
Section 7, Sue, on raising concerns. The two questions I had. Firstly, it talks about routes for raising concern, and I wonder if there should be an extra line there for people who raise concerns outside the system, in other words, for the CQC or whistleblowing, whether we should record that, because we know there have been instances of that. And secondly, the line that is disturbing in there is the line which says detriment experienced, which is very pertinent to our culture at the moment. In other words, there shouldn't be any detriment to anyone raising concerns. And has there been a specific process to follow up those two, which are the most concerning to me?
Thanks, Alan. Sorry, I'm trying to flick between various screens. So the answer to your question is I will go and find out for that with regards to that and make sure that it has been looked into specifically. But yes, your point about potentially putting on any other external concerns raised, I think is a very good idea. So we can certainly include that in the papers going forward.
Okay, thank you.
Thank you, Sue. If there are no further questions on that paper, then thank you, Dan. Thank you, Sue. We will move on to Involvement Committee. Alan, over to you.
Okay. Get my page up. I bolded the items that I wanted to draw attention to make it a bit easier to read. First one is an obvious one. I've mentioned it earlier today already about embedding change, so I won't say any more about that. I don't know whether where James McFarlane's got on that yet, but I think it ties in with what I said to Jude, in that we should be testing ourselves with every change we do, that we are performing suitable engagement. Second bit, I think, is something which is at the heart of Jeremy's reports every month now to the board, which is the people plan. He'll be talking about that at every board, and I think he's building a team to make sure the implementation of that is appropriate. As you know, we've invited a governor to be a member of the committee because we believe that they have a role in involvement, particularly with their members and the community. I think they're pleased about that. And from the next meeting, we will have a governor on the group. And I think it's an important gesture, really, of showing that we're actually taking involvement seriously, and that and it's not just to observe the NEDs or observe the execs at work. It's absolutely fundamental to their role in engaging with the public. I don't need to say any more about maternity whistleblowing. I think we've covered that, but there'll be more work going on about that, which we'll come back to the board on. And the last point is a technical point about the BAF, which I can always take questions on. So I think in general, taking up your earlier question, Sheila, I think the committee is still finding its way. It's a tough one because we don't have data-driven tasks in quite the same way that the other two committees often have. So it's very much about the feel of the organisation, and I think we'll continue to learn how to bring things to that committee, how to be assured, and how to make the most of it. So I think we're getting there, but just slowly.
Note, do we need to approve on the second page of your report, page 179 of convene? The last item is for approval. Now, do we need to approve that formally at board?
I think Anne will tell us. I think Nicola was
nodding.
When we're postulating something from the BAF, I think that's right, and I think we're all happy that that's the right decision, because with Clement's appointment and the increasing role of the ICS, we're absolutely embedded in alliance activities as business as usual.
Yeah. Actually, forgive me, there were two items for approval. So 1, 2, third one down and last one on the page are both for approval. So colleagues, can I take that first for approval? Or Chris, were you raising any issues around those?
No, I'm very happy to support those. It was just a general comment that I wanted to make.
Okay, I'll take it that as a board you approve those, and then Chris, I'll move to your general comments.
Sheila, thank you, and Alan, thank you. And once again, this is work in progress. One of the things that strikes me is that our values are fundamental to everything we do. And actually, when we had the NHS providers presentation to the governors recently, the centrality of behaviours and values was very much part of theirs. And I'm mindful that we've done a refresh of our values. We had a presentation from Helen and others recently, extremely valuable. Perhaps how we're doing on our values and behaviours is something that should sit with the Involvement Committee. And it gives us the chance in a qualitative way to focus on behaviours and the impact that the leadership behaviours have as they cascade through the organisation. That's easier to do in this context than it is possibly in the terms of the more data-driven other committees. So I just put that up for reflection and thought.
Thank you, Chris, and it's a good reflection. We do need to make sure that we focus all our work around our values and our behaviours. So thank you for that. Were there any questions or comments on the involvement report? Alan, was there anything final for you wanted to add?
No, I think we'll take away Chris's suggestion, and I think really the challenge should be to all of us in the room, including us as well, really, to sort of challenge us and say where we think we're falling short on this one. There's so many changes and things going on in the trust all the time. I think we should be able to stand up and say, wait a minute, did we really discuss that properly? And bring that challenge through this committee, if not directly through the executive line. Thank you.
Thank you, Alan. If we could move on then, please, to the People in OD report. Jeremy, it seems a good moment to move across and some synergy there.
Yes, thank you very much. Before I sort of do the segue from Involvement Committee into my report, I want to just take a moment of time out to, in particular, celebrate the contributions of Liz White and Pete Southam, who are detailed in the reports as our Putting You First winners. So Liz, nominated by her professional lead within speech and language therapy. I mean, for something so remarkable, it's a tiny citation, isn't it? It just sounds so matter of fact. You know, she stopped alongside and commenced CPR. Yeah, as you do. It's just an amazing example of you know, just what our staff do both inside and outside of work as, you know, amazing healthcare professionals. So wanted to acknowledge that and say thank you and well done to Liz for being the very epitome of West Suffolk in that particular situation. The description for Pete is, I suppose, more sort of all-encompassing in terms of his leadership and management. As we've referenced several times already today, we spent some time reflecting significantly on how leadership can set the right culture for teams in our organisation, and you've got a real example here. It looks like the sort of team culture we want to see as a result of the right style of leadership. So thank you to Pete, who is a relatively recent joiner to taking on that role within our staff psychology support service. So yes, thank you from all of us to them, to Liz and to Pete. So I think one of the bits of learning that I'd like to get out of my report today is that I'm really conscious that there are some reports here that may well that we may well feel should have gone through the Involvement Committee before they came to board. So you've got some really detailed reports as appendices to my report, which I will make reference to today because they are important. They do lie right at the heart of our responsibilities as a board, but conscious that they haven't been through the Involvement Committee. So it may be that one or more of these needs to do that for fuller scrutiny. But before I do that, I actually want to bring in Amanda. So Amanda has been waiting very patiently today. I've been trying to keep her up to date with the progress of the meeting, and she's stuck with it. So thank you, Amanda. Amanda is one of our two Freedom to Speak Up Guardians, presents to us regularly as a board on their work. Her report is included as an appendix to my own report, but it is her report and James's, not mine. And I want to give her a chance now to present that and to take questions. Amanda.
Thank you, Amanda. And my apologies, we've kept you waiting for so long. Over to you, Amanda. Over to you, Amanda.
I was going to say, I think her name's disappeared from the attendance list.
And I've looked at my phone, and she sent me a text to say she's got another meeting at midday and she may have to step away, given that it's 3 minutes past. That's the answer for that. So she may well return.
Jeremy, please give my apologies to her if she doesn't, because another time we can always move the agenda around and bring somebody in.
Sure. I'll stay on top of that, but she said she will return as soon as possible. So we'll see how we go.
Well, would somebody alert me when she does return? You might want to leave that report and cover anything else, Jeremy.
Of course, thank you. So I will do that.
She's just arrived.
As if by magic, it's the power of the workforce director. She's just reappeared. Amanda, hi.
Hello, I'm so sorry. I had another meeting that I just was saying I couldn't be there when I came back. So
Amanda, for keeping you waiting for so long.
No, don't worry at all. Don't worry.
So I'll hand over to you now.
Okay. Well, thank you very much for inviting me along to your board meeting. And so really, I wanted to start by just saying some things which were in the report, but just contrasting to this time last year. So I've been in post for a year now. James has been in for 11 months. James sends his apologies, by the way. He's off on annual leave this week. If we looked at the period between April and September 22, 3 concerns were raised. If we look at the period this year, from April to September 2021, 32 concerns were raised. Now, we can think that that's because people are having a really terrible time, but actually, as a Freedom to Speak Up Guardian, you know, we know that organisations, and I'm sure you'll know too, that organisations that enable people to speak up are safer organisations. So, you know, I'm really taking that as a positive, and actually, you know, 29 ways that we could have, you know, helped and improved and learned from things that have been going on. So, you know, we're seeing that as a positive. So overall, you know, we are pleased with that. So that's something I wanted to draw out of the report. The other thing was just to say, really, thank you very much, because to everybody who supported us with the Champions Network. So we do feel well supported as Guardians. Denise has given me her budget code, and I've been putting it on lots of forms so I can, you know, buy sandwiches and cakes for the champions when we've had our training days. Jeremy's been very supportive. We've had staff governors. Richard has come along. Union reps, the wellbeing service, they've all come along to help us with our training for the champions. So far we have 48 expressions of interest from staff wanting to be champions, and really committed staff. It's been so uplifting actually to do that, and you know, people really want to make a difference to the organisation. So 48 expressions of interest, 22 people trained already, and we're hoping to launch that in the green sheet next week, and James and I will be in time out as well to celebrate that. So that's all. You know, just kind of a couple of key points that I've taken out of the report there, but I'm just going to hand over really to see if anybody's got any questions.
Thank you, Amanda. And yes, I absolutely agree. The more people who speak up, the more open your organisation is likely to be. It's like, you know, organisations that don't report their SIs or you know, have a very low number. There's always an element of suspicion that people aren't being open. So I think that's fabulous. And what I'm really impressed with is the pace at which you've got the ambassadors going, because we talked about it, it seems not long ago, and the fact you've made so much progress and there's so much interest is fabulous. That's the kind of pace we need to see things tackled within the organisation. So thank you, and my thanks to James as well for the work you've done. Are there any questions for Amanda? Well, we've got her in the room, having recaptured her. No, Richard, did you want to make any comment as a Freedom to Speak Up board champion?
I would only just like to comment, acknowledge that Amanda and James's extraordinary amount of hard work. They've done a fantastic job. It's just amazing what they've achieved, and I absolutely agree that the number of issues raised, the number of people who've come forward is just demonstrates how effective they're being. And I think that the Freedom to Speak Up Champions programme is going to make an enormous difference. If we can have a situation where at the shop floor, as it were, people regard speaking up as just something that they do, it's business as usual, then that'll be fantastic. And I really think we have the opportunity to achieve that.
Thank you, Richard. Jeremy, back to you.
Yeah, I want to overtly acknowledge the even better if suggestions from Amanda and James in their report. This whole area of work is something that is never complete. We will be continually improving our arrangements and support and culture in this area. So what a gift to have things that we can grasp and work on together. And I would propose that we take that through the involvement committee in terms of the plans and scrutiny of the plans to take that forward.
Thank you, Jeremy. And I can see Alan's got his hand up.
Yeah, just agree with that. What's going well, and even better if it's something we should try and sell across the organisation, because it would apply to almost all our roles as NEDs or anybody. I think it's a really thoughtful way of pushing us to continually improve. So thank you for showing how it can be used, Amanda and James.
So I look forward to the in-depth scrutiny from involvement, and you may well be bringing some issues up to board. I have a very strong feeling. So thank you, Jeremy. Thank you, Alan. But above all, thank you, Amanda and James, for the work you're doing. If there are no further questions for Amanda, and again, I apologise for the fact you were kept waiting for so long.
It's okay, that's fine.
Another time we will shift around in the agenda, so I'm sorry about that. Jeremy, can we come back to your main report? Was there anything else you wanted to highlight particularly?
Yeah, before I do, I just wanted to say I certainly see as one of my personal responsibilities the need to look after Amanda and James. They have a role that is semi-independent in the organisation, but they are huge, obviously huge supporters of West Suffolk. They are part of our DNA as Speak Up Guardians, and I will continue to do everything I can to look after them as well as learn from them, given the particular scrutiny around this area. And we know the scrutiny over the course of coming months will only increase with the publication of the Rapid Review report. So I wanted to provide that assurance as well.
Thank you, Jeremy.
So as I mentioned earlier, there are a couple of significant reports attached to my paper. One of them is the annual report on equality, diversity and inclusion. The work on this area is led by our EDI steering group, which does report to the involvement committee. We picked out the highlights in my summary paper of achievements in the last 12 months and also the 4 priorities that we see for the next 12 months. The attached action plan is shown as draft. That is now confirmed. It went through the EDI steering group on Tuesday, where it was approved. So that is there for our adoption and support as a board. So I'd like to overtly do that today. We've touched on several occasions already in this meeting on particular pressures in the organisation, and that clearly is manifested in some of the workforce data that I've highlighted in my report on appraisal and mandatory training. Mandatory training less so, that is just about holding up, so we are still at overall the 90% target, but there'll be peaks and troughs within that, and hotspot areas are identified for the board in the relevant appendix. Appraisal is more of a struggle at the moment, and certainly there are there's some shortfalls there. Typical. So we're at 79% for appraisal, so there's clearly some work there to do, but it is illustrative of what Craig was saying earlier around it is impossible to do everything at the moment, and we're seeing here the manifestation of that, particularly in the appraisal numbers. I know board members have previously remarked about the impact of long COVID on our staff, so we've given you an additional update on that, with 13 known colleagues suffering from long COVID, and it gives you a flavour in the report of the active support that is being provided for staff in that position. So I'm sure you'll find that interesting and something that you may wish to ask about. There's a very detailed education and training report there, which I possibly really can't do justice to in my synopsis, but happy to take questions. And some headlines from the first quarterly staff survey that was undertaken a couple of months ago, which shows a slight reduction in scores compared to the previous national staff survey, but we are now already into the data collection period for the next national staff survey, so it keeps coming. But again, happy to take questions on that as well. Before I pause, there are 2 consultant appointments in anaesthetics, which are detailed in my paper too, so welcome there to Dr. Claire Malcolm and Dr. Ramasamy Radhika. Thank you, Sheila. I'll pause and for questions and discussion.
Thank you, Jeremy. And it's a really rich report, and it's really good to have that much depth in our workforce reports, because I think, you know, workforce are they're our key asset. Absolutely. Do I have any questions or comments? I think there are some papers there, as we've commented, that will go to involvement and something coming up to board. But outside that, I think the detail probably means that you've answered most questions within your paper. Are there any additional comments or questions? In which case, can I thank you very much? As I said, Jeremy, the detail, the richness of this is excellent. And don't worry about Ruby, got Holly, I mean. Thank you. In which case, can I move to the integration report and remind ourselves, actually, that around the integration agenda, we've got lots of staff out in the community, and our colleagues in other sectors are experiencing exactly the same pressure as we are. So we need to be cognizant of that. Clem, can I bring you in, because I believe we haven't got Kate with us?
That is correct. Thank you very much, Sheila. Just wanted to outline that as a system, the paper really outlines as a system how we are responding to the challenges that we're experiencing. As you've stated, the challenges are not only within the acute or NHS settings, but social care are experiencing the very same challenges, in particular rising demand and increased complexity. We are seeing delays in discharges or transfer of care for people receiving support in the community as well as on discharge. And we are really concerned with regards to staff well-being going into winter, and are looking at, as a system, how we collectively support the resilience and well-being of colleagues. We are what we currently have or have outlined in the paper are a number of work streams that we are coordinating collectively in order to support capacity, mainly going into a challenging winter period. And that is focused on various work streams or working groups, which include support to enhance admission avoidance or admission prevention work, work focusing on the high intensity user cohort, as well as work that is looking at improving access and integration with mental health services for crisis support. And this support package is really around the front door of the hospital. I will touch on a couple of key areas, which I know Helen made reference to as part of her operational update, which include the increased bed capacity that has been introduced across West Suffolk to support with our resilience. So there are 45 beds that have been introduced. We have started utilizing those beds and will have the capability to continue to spot purchase should additional bed capacity be required. The process we are working to is to ensure that with smooth transfer of care that is safe and truly is patient-centered, not only on discharging from the acute or the community assessment beds, but also from the additional community reablement beds that have been introduced. So for all the patients who are being discharged into the additional 45 beds that Helen made reference to, we have ensured that as a system, we will provide good wraparound support, which does include therapy intervention and social work input, with weekly multidisciplinary meetings to ensure good planning to support those adults back into the community. In addition to the bed capacity that we have introduced in the residential and nursing homes, we have also worked with St. Nicholas Hospice to increase bed capacity to support end-of-life patients. We are the second area I'm really going to touch on is around the care market, the home care market. So the home care market is extremely fragile at present. And I'm really pleased that as a West Suffolk system, we are collectively looking at how we can navigate this very difficult terrain. And that work includes working with the independent care providers supported by the Suffolk Association. We held a workshop as part of the SNE system to look at collective measures that can be introduced. And those measures are currently being worked through, mainly focusing on quick opportunities that we can do to increase capacity, but there is recognition that longer term work is required to focus on strengthening the care market. Locally, we have really been relying on agency use within Home First and the Support to Go Home team to support with increasing discharge flow. And we are mindful of the challenges continuing to introduce agency brings with ensuring resilience. What we're very cautious of is not compromising on the quality that adults receive once they're discharged or are in the community requiring care. Looking at the long term, I know Helen made reference to a business case that has been agreed to in order to increase capacity within the community health teams, which is extremely positive because that will support with increasing resilience. We have also looked at a business case to support what we are referring to as our responsive offer, which will focus not only on discharge in terms of transfer of care once people leave the hospital, but also community-based support when adults are in crisis in order to prevent further deterioration. And that's extremely helpful. We'll look at, it's being looked at in terms of long-term investment. So this is not a short-term measure, but it's recognizing the capacity gap that we've had in the system. And we are looking to work towards actively recruiting to bridge that capacity gap. I'll also touch on, as part of the report, and I do hope colleagues have had an opportunity to look at the early supported discharge case study, which I think is extremely beneficial and really does go to show the level of work and innovation within services to support and to continue to empower the well-being of our patients. I will lastly touch on the introduction of mental health practitioners into primary care networks, which again we believe will be a really positive step towards increasing resilience and early support for adults who require support from mental health services, working in partnership with primary care as well as the integrated neighbourhood teams. I'll pause there for any particular questions or for discussion.
Can I thank you, Clem, for a really detailed report? There's so much going on, and I do like the use of case studies. I think it brings us back to like the patient stories and reminds us what we're really there for and the real impact we can have on real patients, or your teams on the ground. I mean, and that's fabulous. Alan.
What's going on at the interface? Is it possible that you can develop with the team one or two bits of key data that we could see that actually show results, if you like? So, for example, on delayed discharges, the number of beds that actually are in the community, actual data trends, if you like, so that we can see the results of all the work that's going on. At the moment, I'm not frustrated, but intrigued really to know how that flow, and it'll be part of you helping us understand social care generally, I think. So if there's one or two pilot bits of data that could be perhaps tested with us, I think that will really bring it to life and show that the initiatives are helping our patients.
Certainly, thank you very much for that, Alan. I completely agree. We are currently looking as a system at measures that will help to demonstrate the impact of the changes we are introducing into the system. I will definitely consider with colleagues the best measures to bring to board, which will reflect the impact that is being undertaken within the community.
Thank you. That's really good.
Thank you for the question, Alan, and thank you, Clem. Helen.
Just wanted to follow up on Alan's point, really. I think a number of things we've touched on this morning. So I think the community governance and performance report, Clem and I, when we discussed it earlier this week, talked about getting it going with the data we'd had, but that the ambition would be that that report going through to Insight and potentially to here included social care key metrics as well as part of that being an integrated piece. But the other thing I would just say is they're not new and novel because we do have data and information, and I think the onus is on us is to make it clear to board. So some of the early data in that operational report around the numbers of stranded patients, and that's a bit of an odd definition, but it is the technical definition, and the numbers of medically optimised patients in our beds, etc., etc. We've got all of that information, and we just need to pull that out and make it clear. In all of those metrics at the moment, we are in a worse position, I think, than we've ever been, which is why all the work that Clem is doing will really help. I don't know, I know that Jodie was listening into this, and she's the person who's got the task of adjusting and improving the IQPR, and I think all of this feeds into the improved version of that with some SPC charts as well, which I think will be helpful.
Thank you, Helen, and thank you to Clem and to the team, because it's good to see these reports developing and getting richer in detail, and they help us to get a much clearer view. And I think it may well be that the community and how we work with the community is something the board might want to spend more time exploring in one of its development sessions, because I think, you know, it is so key to the way we work in the future and the way we work with our stakeholder partners in the system. So I have no further questions. So my grateful thanks, Clem, and Helen, we're in the chair. I'll hand over to you for the EPRR core peer review.
Thank you, Sheila. I will try to be brief. We've included the full detail for anybody who's suffering with insomnia, but most people just need to be aware really of the summary of our situation, that page 270 to 272 on convene. So this is an annual process. We do that core review process every year. Last year it was halted due to COVID, and this year it's been significantly reduced. So there's been a review against 46 key standards rather than the full range of 64, plus a deep dive into oxygen provision, which again was not surprising given the challenges that Trust had with oxygen provision as a result of COVID. It's a self-assessment, and as the accountable officer for emergency planning, I'm required to kind of give to you as a board my recommendation being that we are substantially compliant against the 46 standards. There are 3 of those where we are not, where we're only partially compliant, which is why I am making that recommendation. The self-assessment was then reviewed by our emergency planning officer, Barry Moss, myself, and the CQC last week, right towards the end of last week. He agreed with everything other than our assessment. Prior to that review, we had assessed ourselves as fully compliant in terms of the IT data protection and security toolkit. And we had a robust discussion around that and agreed that perhaps there's a little bit of work to do. I am very pleased to report to the board that that there has been a significant amount of work done in just a couple of days by the IT team, supported by Barry. So we have now updated the disaster recovery plan, and that is now already going through for approval. So I expect that to move through quite quickly. That will address the elements of the core standard that we needed to. And I know Barry and the IT team have already put in place a plan to exercise and test that revised plan by the end of November, which will give us by the end of November a position where everything in that regard is fully complete, other than the full implementation of the data protection toolkit, which we already had on a work programme and is in progress. The business continuity has been an ongoing challenge, because obviously going back and doing the theoretical detailed business continuity has been a bit of a challenge, given that we're living in business continuity almost every day. And we'd agreed an alternative approach, really, that gave us a tactical plan that would deal with disaster recovery in the event of any issues around the RAC Plank programme, and that business continuity in other areas was really a subset of that. And we're moving forward with that approach. As it says in the paper, given where we are with the structure, it is, and the constant movement around, it is unlikely we will get to a finished place with business continuity. We are constantly working in that sphere. But of course, the standards review is very black and white. Have you done it all? Is it finished? So we have to say, no, we haven't. But I would not want the board to think this is not the subject of significant focus, and we have recently doubled the capacity in the EPRR team as part of managing it. And the final thing is the decontamination capability at the front door. This is an issue that's outside of our control, really. So we have a mitigated solution that, because we cannot secure training, we need to get training for us in order to then train the trainer to move to full powered respiratory protection suits. That's also an ongoing challenge. It's not one that we just face, that is across a number of organisations. The difference is the protection that people have protects them for a shorter period of time, and therefore we have to keep rotating staff through the decontamination facility, which, to be honest, given that they're very uncomfortable to work in, is perhaps not too much of an issue. But again, we use alternatives and rotate people in through the facility for a shorter time frame. And the final thing I just wanted to say on the back of what appears to be negative was a real comment from the CCG assessor to commend the Trust's approach to its command and control structures and the proactive attitude that we have in terms of addressing the RAC problem. And his comment was that much of the emergency planning response, as well as the estates response, has now become established as regional and national best practice, and that very much is built on the plans that we have developed here, and really wanting to commend Barry Moss for his drive and initiative through that. So other than that, Sheila, I will stop.
Thank you very much indeed, Helen, and thank you for that, and my congratulations to Barry and to the team, and to yourself as leader. You know, it is good to see our expertise acknowledged more widely. It's a very thorough report. I haven't got any hands up for questions. I think we can probably take it as self-explanatory. Was there anybody who wanted to add anything to it? Chris?
Just a very quick question. Firstly, Helen, thank you very much indeed. I mean, it is a tough read because it's very small and there's lots and lots of pages. Two questions. How does it link into the BAF? And I know that we're coming on to the BAF shortly. And secondly, which of our governance committees really should oversee this?
So it goes through the Health and Safety Committee, which then feeds through into, just trying to think, that one feeds through to the standards. It does come through and into Insight Committee, but it reports through to the Health and Safety Committee. That's where it's always sat in that regard. The RAC issue is on the BAF. So if there were specific issues, they would flow through to the BAF. Emergency planning per se is not on the BAF, and this is just our assessment against the various elements. So the decontamination issue is a risk on the trust risk register, but it's not. It doesn't come through fully onto the BAF, but it's recorded on the risk register, if that helps.
Okay, I think because it's a really useful document with lots of really wicked issues on it, and I think certainly in terms of us as a board, sort of forward horizon scanning, you know, what are our state of preparedness, which is reflected in this document. We just need to sort of think, I think, through how we use it constructively in terms of our board preparedness and forward thinking.
So can I perhaps make a suggestion, because this is our self-assessment with the CCG's oversight that's now gone up to NHS England. There will be a point that it'll come back down again in due course with any commentary from them. That might be then an appropriate time to maybe do a deep dive in one of the other governance committees, or even bearing in mind the huge content here for it, the subject of a workshop that you might want to do.
That's a very
Great
good
idea. Thank you.
Thank you very much. And in the interest of time, because I failed miserably today to keep to time, we will move on at that point. But thank you for that, Helen, and thank you for a great piece of work from the team. Trust strategy. Helen, other Helen.
Thanks, Sheila. I'll keep this very brief. You should be all by now be familiar with the report and know that we carried out extended consultation. The strategy has now been through the reader panel, and feedback from the panel has been incorporated into the document, and the case studies have now been added. So this is the final version. It's now gone into design phase, and excitingly, Anna and I had a script meeting with the animators this week, which was really exciting, really good. So the idea is that we'll produce a package of collateral to communicate the strategy with. So that will include an animation, a designed report, and some visuals that we'll be able to use through our communications channels. We're also putting together a comms plan for the launch, and we anticipate that the collateral will be ready before Christmas. Happy to take any questions.
That's fantastic, Helen. I'm really looking forward to seeing the animations, having seen some examples of our work. I think we've got a really sound, solid piece of work here. We look forward to seeing it, I was going to say polished, you know, into its more glossy formats.
Exactly, it'll be good.
It's not a glossy document to just keep on the shelf. It's absolutely underpins what we do. I can't see any questions. We've spent a long time on this, so thank you, and we really look forward to the update on the launch and on seeing the detail of presentation. So thank you for that. In which case, I'll move to Future Systems Board report. We haven't got Kate. Is there anything on that anybody wish to pick up, or can we take it as read? And we've spent quite a bit of time on it in various locales. Craig, anything you wanted to add?
No, I think you've just said it, Sheila. We've we've discussed this and presented this information at a number of forums.
Thank you. Risk appetite statement, Anne, and can I thank you for the workshop you did recently with the board? I think it was really useful.
This statement is the outcome from that workshop. So this is very much your board statement, and it sets the parameters for the risks that you are willing to tolerate and bear. It isn't hugely different from the old risk appetite statement, but is marginally, we are more risk averse than we were. And the biggest difference is that we have separated quality into patient safety, patient experience and clinical effectiveness, accepting that there are different risk parameters for those, with the most risk averse, of course, being patient safety. Happy to take any questions, but otherwise take it as read.
Thank you. It's good to see the outcome of that work. And that was a great workshop. So thank you for that. Are you happy then that that represents the output of that workshop? Yeah. Okay, we'll move to the BAF then, please, Anne.
Yeah, the BAF hasn't changed since the previous report to the board, other than the removal of pathology and the alliance from the strategic risks. We're about to go into a review session with the executive directors, because now that we've approved the risk appetite statement, we need to reflect to see whether the risk parameters are right. I mean, I don't think it will change the risk entries that we've got in the BAF, but it may affect the actions that we're taking to address those risks.
Thank you very much. And can I ask, as a board, are you happy to agree the recommendations on page 318 of Convene? I'm seeing nods and I'm not seeing any hands up. So if you're happy to accept those recommendations, if there are no questions, then we will move on to your governance report, Anne.
Again, please take the report as read, and I'm happy to take any questions arising from it.
Thank you. Were there any questions? I don't think so, but Anne, I don't want anybody to think we're skidding through your papers and ignoring the fact that they represent a huge amount of work. So thank you. There's no questions, so we will move on to any other business. I have one which I want to cover, and one which I think's emerged during the course of the discussion. I think we recognise that as a board we need time to discuss some very difficult topics, and I think one that I want to note is the debate on what we don't do, you know, that kind of realistic as a board, and it fits to me with our risk appetite of what we are prepared to risk, if you like, in the bigger picture. So I think we need to pick, but on I was going to say a nicer note, but it isn't, it's a sad note. This is Helen Beck's last board meeting, and we cannot let that go unnoted. I know that I will say farewell to Helen a number of times over the coming period, but on both a board level and a personal level, Helen, you will be very deeply missed by the organisation. You represent that solid NHS set of values in the way that you behave professionally and personally. You have been an enormous support to the board, to myself, to everybody in the room, and we really do wish you well. It will not be quite the same without you in the room. I know that Nicola will be superb at your job, but we shall miss you as an individual from the team. You've proved a stalwart for West Suffolk, and I know that you have been in the NHS for so many years. The NHS owes you a debt, we owe you a debt, and I just want to say thank you.
Thank you.
At this point, before I bring you in, Helen, I know that Liz wants to have a word on behalf of the governors. So Liz, if you're still there, before Helen responds, I'll let you embarrass her as well.
Well, I'm still here, waiting and anxious. Well, Helen, I can only say thank you personally from myself and also from the governors. You've never hesitated when we've put difficult questions to you. You've come back with sharp and accurate answers. And if you haven't, And if you haven't, you've gone away and looked for it. And when we come into Quint's house, there's always a smile, a happy, cheery hello, and we will certainly all miss that. And I'm just going to say one thing. It's never been in my case. It won't be in yours, I'm sure. Enjoy your retirement. But I know from a personal experience, and Sheila will tell you, you're even more busy when you're retired. So have a few weeks off and then look forward to what comes next. But Helen, from myself, during my personal problems that I had, thank you and enjoy life after retirement.
Edgeways.
I'm really conscious to keep this brief, but thank you both for that. I have thoroughly enjoyed my time here at West Suffolk. It has been a huge challenge. I don't believe in regrets, but if I had a regret, my only regret is that I didn't come here sooner, because this has been absolutely the pinnacle, and I've loved my time here. I've said to a couple of people, retiring almost feels as if I've put a child up for adoption, because it's you know, it's quite a difficult thing to do, but I agree. Nicola will be absolutely fabulous, and I just wish you all the absolute best of luck as you move through into a very difficult, challenging time. But I think you've got the people and the drive to succeed, and I wish you all absolute good luck with that.
Thank you, Helen. And I know that those of you can find the clap button are, but we will find a number of ways to say goodbye to you, I know. So there will be, I'm afraid there will be several of these to come, I suspect, Helen, but they are sincerely meant, very sincerely meant. Right, I'm going to note the date of the next meeting, and I'm going to close this meeting. For the board members, I think we should be in the next meeting. So I'm going to suggest, are you happy if we take a quarter of an hour? Which brings us a little bit back on time. Is everybody content with that? Okay, I'm really sorry. So any of you that were going to run over to time out if you're in the hospital may not make it. In which case, I will see you back in quarter of an hour. And can I thank everybody and thank our attendees too from outside. Thank you all and have a good weekend.